All right, chapter 66, normal labor, delivery, and postpartum care. I ain't have time to do this shit because school start tomorrow. We got to get it how we live. Let's just read this shit. So labor and birth as normal, labor and birth as normal processes. Um, if I say I think I'll highlight this and that, just do it that way. Like use your book. I don't have the new book in front of me, but I do. But I'm just going to use this and then I'll go back through my new book tomorrow. Okay, so and see if it's anything important that we need to know, and I'll like leave a message in here saying what page to look at. Man, fuck that. Let me get my new book open. Chapter 66, because I like to do shit right. And knowing my black ass, I'm gonna record this video. Okay, so we learned about what we learned about in chapter 65. So let's start right here. A woman body is designed for conceiving, carrying, and bearing children. The process of labor is normal, but it is a process that most women experience only a few times in their lives. It is an intense process, requires enormous amounts of physical and emotional energy. So, what we're about to learn about in chapter 66 is how to promote the normal progression of labor and how to recognize signs of possible complications. So that's all 66 is talking about. Labor and birth at normal processes. We want to know what's normal. And then we also need to be able to recognize signs of complications. So basically this is like a health assessment. Know what the normal is and know what the abnormal is. And we're also going to know learn about the emotional needs of laboring women and the family. And although most families have looked forward to delivery for many months, the individual involved will have unique concerns. As a nurse, we know we're going to encourage, support, educate the family and the mother to be during intense, because labor is intense. So during this intense event, through the nursing process, nurses, us, we can provide comprehensive care to the growing family. Care for observation of the both the mother and newborns are necessary after delivery. You will perform tasks that prevent the development of complications and promote rapid healing of tissues. You will also function as a teacher to provide knowledge. We already said this shit again. Whether this baby is the client's first child or her fifth, each baby brings changes and challenges to the new parent. So it doesn't matter how many kids she have, every birth is going to be different. So, according to the culture and ethnicity, family, this is a special consideration, family involvement in the birth process. Most traditional Cuban fathers are not allowed in the birth process at all. Never knew that shit. That's crazy. So, we say the level of all father participation depends on the wife's level of education and assimilation into the American culture. The pregnant woman's mother may be present during the entire labor and delivery. The laboring women will usually assume a more passive role than her mother, who will try to involve all activities. In Roma families, the father well, in Roma families, the father stays outside the birth room due to modesty about birth events. Okay, so we learned about what goes on in Cuban culture and what goes on in the Roma culture. Now, the four stages of labor. Labor is a series of events during which a woman uterus contracts and expels a fetus and completes the process. There are four stages of labor. I would know these, and it's going to be up here somewhere. I would know all four stages. The first stage is dilation. Let me, I'm marking it in my book so I can remember it. I'm marking no. This is something that we need to know. Um, my dad out of all the goddamn highlighters and pens. Here we go. So the four stages of labor. No. So the first thing we would need to know, stage one, dilation. Dilation, this is uterine contraction, also called labor contraction, cause the cervical OS, the mouth, cervical os, which is the mouth of the cervix, to open, dilate, and well, when we say open, it means dilate, and move the fetus downward into the birth canal. Stage one has three phases. Stage one has three phases. It got Latin, active, and transitional. Latin, active, and transitional. In stage two, you got expulsion. And what expulsion is, it's the uterine contraction. It continue and increase in intensity until the baby is delivered through the vaginal opening. Stage three, we got placental. Placenta is the uterine contraction. It expels the placenta after the delivery of the newborn. That's what stage three is, placental. Stage four is the recovery stage. Uterine contraction continue and close off open blood vessels to prevent excessive blood loss. So we're going to read those stages again. Stage one is dilation. That's uterine contraction, also called labor contraction, causes the cervical os, which is the mouth of the cervix, to open, meaning dilate, and move the fetus downward into the birth canal. Stage one has three phases. You got Latin, active, and transitional. Stage two is expulsion. And what expulsion is, the uterine contraction continue and increase in intensity until the baby is delivered through the vaginal opening. Stage three, placental. Uterine contraction expel the placenta after the delivery of the newborn. And then stage four is the recovery stage. Uterine contraction continue and close off open blood vessels to prevent excessive blood loss. There's many theories, but no one is certain about the cause, what causes labor to begin. There's theories out there, but we don't know. And I think that would be important if something on the test asks a mother want to know what causes labor. Shit, we don't know. Approximately 38 weeks after fertilization, the 40th week after the last menstrual period, the fetus is ready to be born. And we learned that in the last in chapter 65. So approximately 38 weeks after fertilization, the 40th week after the last menstrual period, the fetus is ready to be born. Intrapartum is the time period during which labor and delivery takes place. It is followed by the postpartum period, which lasts until the end of the 6th week after birth. So intrapartum is the time period during which labor and delivery take place. It is followed by the postpartum period, which lasts until the end of the 6th week after the birth. Choices in labor and births. So there's going to be some choices, and I would know this. I would definitely know this. We already know this about when the baby ready to come out, about that 40th week. So know what intrapartum is. Once again, intrapartum is the time period during which labor and delivery takes place. It is followed by the postpartum period, which lasts until the end of the 6th week after birth. Choices in labor and birth. And we know after the postpartum, after those 6 weeks, it's time for the woman, no sex during that time. This is after the baby has been born, and it's time for the client to, go to the hospital, get her checkup. Okay. So let's talk about the choices and labor and birth. Because each birth is an important life event, many women and their families have a clear sense of what they would like to occur during pregnancy, well, during the process. There are choices in many areas in intrapartum care. What we say intrapartum care is the time period during which labor and delivery take place. It is followed by postpartum. So intrapartum is the period during which labor and delivery takes place. So the following are some, okay, right here. So these are going to be the followings that are some options to be considered for the choices in labor and birth. Birth attendant. One of the choices an expected family makes is the healthcare provider. So the family is going to come up with who they want to provide for the mother to be, or the mother is going to plan that. Many women choose physicians who may be specialists in either family practice or OB. Other women choose to review pregnancy and birth care from a certified nurse midwife. We talked about all of this last chapter. Women who have received prenatal care from a nurse practitioner or physician assistant PA or NP will have a different care provider for the birth. The role of these professionals does not include attending at birth. I will know this right here. The certified, I mean, just because you got a nurse practitioner and a PA, the role of these professionals does not include attending at birth. Okay, that's what I would include. Settings. Another choice families can make when preparing for birth is the setting for the event. Most women choose to deliver in a hospital setting. In the hospital, they may be assigned to a traditional labor and delivery unit in which the woman labors in the room and then is taken to the delivery room for the birth. Or they may be placed in a birthing room in which both the labor and delivery take place. In some hospitals, these rooms are called LDRP. This is, I would know all of these: birthing room, LDR, or labor delivery recovery postpartum rooms. A freestanding, not in the hospital, birth center. So it's a freestanding, which is a birth center, is another option for giving birth. Freestanding birth centers promote the concept of safe, satisfying, and cost effective childbirth. The National Association of Childbearing Centers has developed standards and criteria for the care and safety in childbirth centers. Finally, women may choose to give birth at home. Home births may be attended by a certified nurse, midwife, or less frequently a physician. It's mainly going to be a certified nurse, midwife for at home birth. One reason some women choose the option is that the home is their territory, which is not the case in either a birth center or a hospital. Only women in healthcare, I'm sorry, only women in good general health whose pregnancies have progressed normally should be candidates for any type of out of hospital. This is what we need to know. So if she's not a high risk, if this is not a high risk pregnancy, sure, she can have the baby at home or at a birth center. But if she's a high risk and if she's showing signs of complication, she got to have that baby to the hospital. At the first sign of complication, if a mother, did seem healthy and everything was going good, but it's a first sign of complication going on when she's trying to have that baby at the birth center or at the home, she needs to be transferred to a hospital to ensure that the safety of both the mother and baby. Now, when we talk about a birth plan, we're talking about, hold on. So, with the birth plan, give me one second. Okay, so with the birth plan, a birth plan is a written document in which the expectant mother expresses her desire for labor and birth. Highlight that. A birth plan is a written document in which the expectant mother expresses her desires for labor and birth. Some briefs, whereas others are long and very detailed. Some items that may be included are the woman's choice of a partner for supporting during labor, the type of pain relief measures the woman desires, the woman's feeling about having an IV, electronic fetal monitoring, or a epi, epsios, epsi, ep, episiotomy. That's is that incision is going to be made, like when you got to get cut. It is the nurse roles to inform the woman or couple preparing a labor plan of the policy of the birth setting and birth attendant and of the need for flexibility. If complications develop, the family should discuss the birth plan with their health care provider before the onset of labor. Okay, so this is an NCLEX alert to know is the nursing students should be especially alert to important terminology. That's all the fuck we need to know from that. The process of labor. So lie, presentation, station, and position. Live presentation, station, and position. So to understand the process of labor and delivery, it is helpful to understand the relationship of the fetal body to the maternal body. Several terms are used to describe how the fetus is lying within the mother. So, with lie is a term used to compare the position of the fetal spinal cord, which is that long part, to that of the woman. The normal lie of the fetus is longitudinal. That's up and down. I would know that. Longitudinal, up and down, which means that the fetal spine is parallel to the woman's. I would know that. So parallel means line, straight up and down, line. Like it's going to be parallel to the female spine. So the female spine is straight up and down like this. Guess what? The baby spine is straight up and down. In the transverse line, that means something that is across. The fetus is lying crosswise in the uterus and cannot be delivered until the lie is altered. So before that, this is the process of labor we're talking about. You know damn well when we say transverse, that means something across. That means that baby is lying sideways, just like this. It's a cross. So we're not going to have how the fuck the baby gonna come out sideways. So you know that baby is going to have to be turned longitudinal, up and down. If I'm saying longitudinal, however you pronounce that shit, the baby got to be up and down. We are not having no baby come out sideways. That shit is not going to happen. So that baby can't be delivered until it's parallel with the mother's spine. That means straight up and down. Presentation refers to the body part of the fetus that lies closest to the pelvis and will enter the birth canal first. Presentation, I will highlight that, refers to the body part of the fetus that lies closest to the pelvis and will enter the birth canal first. The usual presentating part is the head. This is a cephalic presentation. Some people call this a vertex presentation. However, vertex is only one type of cephalic presentation. I would know exactly what vertex is. Vertex presentation occurs when the fetal head is flexed well against the fetal chest. Once again, vertex presentation, it occurs when the fetal head is flexed well against the fetal position. Vertex presentation occurs when the fetal head is flexed well against the fetal chest. Other types of cephalic presentation include face presentation and brow presentation. So, other types of cephalic presentation includes face presentation and brow presentation. When the buttock, foot, or knee, and so all of this, I would definitely look at the figures. Let me go to the figures real fast. This is it right here. So, we got right here left occipital anterior, left occipital transverse, left occipital posterior. So anterior mean the front. This is the front part. This is what's going on in the front. Transverse mean straight across. This is what's going on. This is what it's looking like straight across. And then occipital posterior. This is the back. This is what's going on in the back. Now, left mental anterior. I don't think we talk about that right. We ain't said nothing about that yet. Um, I don't remember saying that. Let's keep reading. Uh, oh, yes, we did. Just say other types of cephalic presentation includes face presentation and brow presentation. It just said other types. I wouldn't too much get stuck on it because it just gave you a sweet and short ass other types. That's all it said. It didn't go into talking about the types and nothing. So when the buttocks, foot, or knee is the presenting lowest part, that means that baby is breech. You have to know that. You have to know that. So when the foot is trying to come out, when that booty trying to come out, when the knee trying to come out, that is a breech presentation. So that is that's complicated labor often occurs when body parts other than the fetal head presents. Know that. This is important to know. This is very important to know. If their head is not coming out first, that's a breech baby. So we gonna have to pretty much, I don't know if that's what the doctor does, push that bitch back up there and flip it around so we can see the head. But that's a breech baby. And depending on if it's a complication and health risk, the baby at health risk, that's when you may go into emergency C-section. But I ain't even finna skip. We'll learn more about that. Rally the shoulders may be presenting part. If the fetus is lying in a transverse horizontal position. So if that baby is if you start seeing the shoulder of that baby is in a transverse position. That means that baby is sideways. If the fetus cannot be turned from his shoulder presentation to a cephalic, meaning a head presentation, the baby must be delivered by cesarean birth. So if we can't get that baby pushed back up in there and get the head, I just said that it's gonna have to be a C-section. I think this sentence is important to know as well. This one is important to know, and this one is important to know. I would definitely highlight those. So let me look at my new book. I'll make sure everything is in alignment with the new book. Um, Also the book talks about going back a little bit, unfortunately, because it doesn't show it in this book. Yeah, it talks about family involvement and stuff like that, but it doesn't talk about a doula. And a doula is this is also talking about special consideration, and this may not be on the test, but if it is a doula or a birth assistant, this is traditional. A lot of Hispanic people use doulas, and it say it's a doula is just a birth assistant. It's like a when they don't want a certified nurse wife or midwife, or when they don't want a doctor, they may have a doula. And it's a traditionally a respected woman in a community who provides emotional support, basic advice, and health care during pregnancy. This woman assists the birth attendant or midwife, sometimes referred to as a birth worker, labor support person, or childbirth educator. The doula works with the expectant family, providing education of the obstetrical needs and childbirth processes. You'll see that on page 1043. I'm sorry, I had to go back. I forgot to look in the book along with the old book. But that's on page 1043 in the new book. We're talking about a doula. I said that Erica Badu was a certified midwife. I don't think that's exactly what she is. That's what they're calling her, but she is more like a doula because she doesn't have a nursing license. She's not a licensed nurse. She doesn't have that type of education as far as being a certified nurse midwife, but she's definitely a doula. Okay, so that looked like that was it in the new book that we needed to know. So we're back on track with this. We're still talking about the process of labor. So station refers to the descent level of the fetal presenting part into the birth canal. I would know this. Station refers to the descent level of the fetal presenting part into the birth canal. So station is measured as the relationship of the fetal part's lowest bony portion of the level of the ischial spine of the woman's pelvic bone. The station is measured as the relationship of the fetal presenting part's lowest bony portion to the level of the ischial spine of the woman's pelvic bone. Now, that's going to be in 66-2. That's right here. The station of the fetal head. This diagram shows the relationship of the fetal head to the pelvic bone, specifically the ischial spine during the labor and delivery process. Station 0 represents the level of ischial spine. So this is level 3, level -3, -2, -1, 0. And this is when she started to dilate. 1, 2, 3. Okay. Well, I don't think there's dilate because that ain't what it said. Don't have me making shit up. Okay, so let's keep reading and see. During pregnancy, the fetus is floating in the amniotic fluid, what we learned in chapter 65, above the level of the symphysis pubis. Near term, the fetal presenting part dips into the pelvis, but can still be dislodged upwards. Engagement is the term Used when the fetal head has moved downward in the birth canal until it can no longer be pushed up and out of the pelvis. So know that. Engagement is a term used when the fetal head has moved downward in the birth canal until it can no longer be pushed up and out of the pelvis. In um in newly parous first time delivery women, engagement often occurs before the onset of the labor. I would know that, and that's going to be up in here somewhere. So, in newly parous, this is first time delivery women. Engagement often occurs before the onset of labor. In parous, having a history of more than one birth, that's parous, having a history of more than one birth, women engagement usually occurs during labor. Engage in Aquarius women, I'm sorry, in Aquarius women, engagement usually occurs during labor. And Aquarius again means having a history of more than one birth. Now, in this box right here, the box 66-1, it contains some terms related to pregnancy and birth that are important for us to know. So, in this box, it says newly gravida or gravida or gravida. It refers to a woman who has never been pregnant. This is a woman who's never been pregnant. Newly gravida refers to a woman who has never been pregnant. Newly para refers to a woman who has never delivered a live child, also seen as para zero. That means she's never had a live child. She's been pregnant, but she's never delivered a living child. So more than likely, that would be like stillbirth. Um, she's delivered, but the baby wasn't alive. Primate gravida, we know that is going to be, this is the lady first time having the baby, first time pregnant. Relates to the woman who is pregnant for the first time. Not that she had a baby, but relates to the woman who is pregnant for the first time she's pregnant. Multigravida is the term of a woman who has had more than one pregnancy. Primate para is the term for a woman who has given birth to one child. So she only had one child. Because para, remember that key word, para, that is the mother and the baby that are apart. That they're the baby and the mother itself. So the mother that had the baby. Okay. And remember that we learned that in the last chapter 65. So go back if you forgot what para means. And then in multipara, it said is a woman who has given birth to more than one viable infant. That means that baby is alive. That baby is, thriving. Multi-para is a woman who has given birth to more than one viable infant. I will know every last one of these hoes. Okay. The station at which the fetus is said to be fully engaged is called station zero. See, I told you I ain't know nothing about this shit. Uh, you know what? That is what it means. The centimeters. I know what the fuck I be talking about. So the station at which the fetus is said to be fully engaged is called station zero. That is the widest part of the presenting part of the fetus has lodged into the pelvic inlet. The lowest part of the fetal skull is at the level of the mother's ischial spine. And going back, and we saw that. Let's see how station zero, that's -3. So that's going to be the ischial spine. So the lowest part. Okay, so the other stations are measured in centimeters above or below station zero. So I was absolutely correct about the centimeters. When the presenting part is higher above the level of the ischial spine, the station is expressed with a negative number. So right here, when the presenting part is higher above the level of the ischial spine, the station is expressed with a negative number. The key word is when it's higher above the level. I'm sorry, higher above the level. The ischial spine, the station is expressed with a negative number. Like -1 station is 1 centimeter above the spine. -2 station is 2 centimeters above the spine. Now, when the presenting part descends further into the pelvis, the station is expressed as a positive number. +1, that's a positive station. That's going to be 1 centimeter below the spine. Okay. Again, use the centimeters as the measuring guide. A station of -15 is considered floating, whereas a station of +5 means the fetal head is in the vaginal opening. So -15, that baby is still in the, up there floating around doing this thing. But when it gets to +5, that's like 5 centimeters. You have dilated 5 centimeters, and that means that that baby head is right there at the vaginal opening, and that bitch almost out. Um, position refers to the relationship between standardized points on the presenting part of the fetus to a designated point on one of four quadrants of the woman's pelvis. Position, it refers to, I would know what position means. Position refers to the relationship between standardized points on the presenting part of the fetus to a designated point on one of four quadrants of the woman's pelvic. The standardized or assigned pelvic can include the occipital bone, which is going to be just O, the occipital bone, the chin of the mentum, which is just M, the buttocks or sacrum, which is abbreviated with S, and the scapula or acromion process, which is going to be abbreviated with the A. The presenting parts are occiput, mentum, sacrum, and acromion is labeled in relationship to a designated point of one of the four quadrants of the maternal pelvic. So right anterior, left anterior, right posterior, and left posterior. There are several positions for a fetus in any presentation, and it refers to 66-1. So this is the shit I was reading too early. So left occipital, occipital anterior. This is from the left view. Transverse mean across. So see how that's across. And this is still from the left, but this is posterior. So this is from the back. And we finna find out what that mental shit means. So as far as these, you might need to know. I would definitely, with these, you probably do need to know. I would know it. It's a position part. It's the occipital bone. A vertex presentation is designated. So in 66-1A, this right here, it says it it shows three positions in three left vertex occiput presentation. I would know it, and I would know what it looks like just in case they put pictures, they put images on the test. I would know it, what it looks like. If the assigned part is the mentum, a face presentation is designated. Figure 66-1 is going to show it, dash B. Okay, so this is left. You see the baby face. This is left. This is that baby trying to, well, this is the mental transverse. You see the face. That's how the baby is coming out. This is what it look like. See? And this is fine. Just as long as that bitch ain't, that baby ain't sideways trying to come up out of that. That ain't right. And then this is the posterior. It's coming out backwards. So this is the front of the baby coming out. This is the baby coming out sideways, or the baby coming out, you know, when the baby come out through the vagina, because this is the front part of the vagina. So when it comes out, this is what you see. It's the back side, or you're gonna see the side, or you're gonna see the front part of the baby, the anterior. This ain't right. We don't want to see no baby balls and booty and cooter cat or whatever coming out like this. This is a breech baby. This is breech. Now you gotta take your ass back up in there. And we're gonna have to turn your motherfucking ass around. Okay. Um, right here, say if a sign part is the shoulder or acromion process, a shoulder presentation is designated. In shoulder presentation, or in shoulder presentation position, the fetus is on a transverse line. The shoulder, arm, backside, or abdomen may be the presenting part. So we don't want to see a shoulder is transverse. That's a baby. We don't want to see that. We don't want that baby coming out like that. That's dangerous. Baby head is supposed to come out. So right here it says it. Breech presentation. Each position can be left or right, and interior, posterior, or transverse. Each presentation has a possibility of six positions. This is what I would know. LOA, which is left occipital anterior. LOP, which is left occiput posterior, um, or occiput posterior. LOT is left occiput transverse. ROA is right occipital anterior. ROP is right occiput posterior, and ROT is right occiput transverse. I would know that, right. I would know this, and I would know what this is. I think this is very important to know because this is especially when we get down here to C, which is the breech. That would be abnormal for the baby to come out that way. So moving down, let's talk about this. Let's continue to talk about this. If the assigned part is buttocks or sacrum, a breech presentation is designated. And we just looked at the breech presentation. And it's going to show three breech sacrum positions and three left. We just went through that. I would variation of breech position include, I would know every last one of these. Because this is not right, baby, not supposed to come out like that. So complete breech, frank breech, kneeling breech, footling breech. With complete breech, the fetus has both legs drawn up, bent at both the hip and the knee. Complete breech. That's a complete breech. The fetus has both legs drawn up, bent at both the hip and the knee. Frank breech is the fetus has the hips bent, but the knees are extended. Frank breech is the fetus has the hips bent, but the knees are extended. Kneeling breech. Kneeling breech is either one or both legs are extended at the knee. Kneeling breech. Either one or both legs are extended at the hip, flexed at the knee. That's the kneeling breech. Either one or both legs are extended at the hip, flexed at the knee, because it's kneeling, so it's flexed at the knee. And footling breech, either one or both legs are extended both at the hip or knee. Footling breech, either one or both legs are extended both at the hip and the knee. So when I look at complete breech, it said the fetus has both legs drawn up, bent at both the hip and the knee. The only this what makes complete stand out stand out towards, I mean, compared to the other ones. Drawn up. Complete breech, drawn up. Drawn up, bent in both at the hip and knee. The fetus has both legs drawn up. This is what I'm remembering. Of course, I know it's going to be bent at the both the hip and knee, but this is what I mainly would remember. Frank breech, the fetus has the hips bent, but the knees are extended. When I think of Frank, when I see the word Frank, I'm thinking about a plank. Because plank, you're like, when people do planks, they look like a board, like they're straight out. When you're doing the exercise, the plank, if you don't know what it is, look on Google and look at a plank. And I'm just rhyming plank with Frank. And plank, you're pretty much extended. Your body is extended out when you are plank. So a Frank breech is the fetus has the hips bent, but the knees are extended. And kneeling breech, I'm looking at your knee, you're knee, kneeling. So that's what stands out to me on that. And okay, with kneeling breech, it said either one or both legs are extended at the hip, flexed at the knee. And footling breech, either one or both legs are extended, both at the hip and the knee. Footling breech, either one or both legs are extended, both at the hip and knee. And with this one, it say the fetus has the hips bent, but the knees are extended. So don't get footling and frank mixed up. Footling is either one or both legs are extended at both the hip and knee. And frank is the fetus has the hips bent, but the knees are extended. So the hips are bent. But footling, both the hip and knee Either one or both legs are extended, both at the hip and the knee. And Frank, the hips are bent, but that knee is extended. The knees are extended. So I would definitely know those. I said that a whole bunch of times because I know there's some shit that will be on the test. In all types of breech presentation positions, the sacrum is the assigned point. The sacrum, that's that booty, it's a sign point. After you learn which body parts it's presenting, you can then accurately describe the position of any fetus. For example, the occiput, the occiput may be on the woman right or left side, and the interior, posterior, or transverse area of the pelvic opening. These positions are often designated by the OB personnel and recorded and initialed in the charts. A fetus with the occiput in the left side of the interior portion of the mother's pelvis could be described as LOA, which is left occiput anterior. And we went over that already. This is something important to know, key concept. Some positions of the fetus make delivery difficult or dangerous. For example, in the footling breech position, there is a chance the umbilical cord can prolapse because there is so much empty space with the uterus. This could cut off the blood and oxygen supply to the fetus before it is born. Know that. Know that. Some positions of the fetus makes delivery difficult or dangerous. For example, in the footling breech position, there's a chance the umbilical cord could prolapse because there is so much empty space within the uterus. This could cut off the blood and often, I mean, blood and oxygen supply to the fetus before it is born. Um, Let me see what my book says. Okay, let's just keep going. Pretty much on track for everything. I don't see anything different from what the new book is saying. Signs that labor is approaching. The common variable of labor known as the four P's. Know about the four P's: the passage, passenger, power, and psyche. The passage, passenger, powers, and psyche. These are the common variables of labor known as the four P's of labor. Okay, so the passage includes the diameter of the body pelvis and its soft tissue. The passage includes the diameter of the body pelvis and its soft tissue. The passage includes the diameter of the body pelvis and its soft tissues. The passenger includes the fetus, umbilical cord, and placenta. The passenger includes the fetus, umbilical cord, and placenta. The powers or the uterine contraction. Hell yeah. The uterine contraction, that's the power, baby. And the psyche includes the process of birthing, the attitude and behavior of parents, and the evaluation process of the stage of the labor. The psyche includes the process of birthing, the attitude and behavior of the parents, and the evaluation process of the stages of labor. I would definitely know all about the four P's. Even if we didn't know now, I would know what the fuck they stand for. I sure will. Or I sure would. Lightning. Lightning is the settling of the fetus into the pelvis. Lightning is the settling of the fetus into the pelvis. Lay people often say the baby has dropped. Lightning usually occurs 2 to 3 weeks before the onset of the labor in women who's having the first child. That's prima gravidas or gravidas. If the client is a multigravida, has had more than one pregnancy, lightning may not occur until labor begins. Okay. If the client is a multigravida, has had, meaning if she's had more than one pregnancy, lightning may not occur until labor begins. But in a woman that has already, I mean not already, but if it's her first baby, lightning usually occurs 2 to 3 weeks before the onset of the labor in women having their first child. So on that test, if it's a question about lightning, I think it'd be something with these two. Lightning usually occurs 2 to 3 weeks before the onset of the labor in women having their first child, prima gravidis. Lightning is the selling of the fetus into the pelvis. Lay people often say the baby has dropped. It's basically what they're talking about. This, I think, all of this is what's going to be on there when we say the baby has dropped. Instead of saying selling of the fetus into the pelvis. No, the baby has dropped. Everybody say that, but still know about the settling of the fetus into the pelvis. The baby that's settled into into the pelvis. Okay. Okay, so although lightning allows the pregnant woman to breathe more easily, she will notice an increase in pelvic pressure and urinary frequency, and may also have leg cramps and increased leg edema. Okay, although lightning is gonna, the mother's able to breathe easier or easily. She's gonna have pressure and urinary frequency, and may also have leg cramps and increased edema. I would know that too, but I think this first part is the most important. But I would still know that whole, what's going on. Breast and hip contraction during pregnancy, late stages. The uterine muscle prepares to labor and delivery by tightening and relaxing at intervals. These contractions, called breast and hip contractions, are usually painless, short, and irregular. They are also known as false labor. Breast and hips are known as false labor. Know that. That is what I would know. As labor approaches, these contractions may become stronger and somewhat regular. The woman may sometimes mistake the false labor contractions for true labor. She may experience false labor anytime in the last trimester, but more often during the final 2 or 3 weeks of pregnancy. A change in activity may provide the woman some relief. A change in activity may provide the woman some relief. Okay. So that is all we need to know from Braxton Hicks. And I think this is very important to know about Braxton Hicks. These are contractions and they're known as false labors. Braxton Hicks. Show. A mucus plug sealed the cervix during pregnancy. Just before labor, the cervix opens slightly and this plug dislodges. So when that plug dislodges, it's like wet. It's wet. So at the same time, capillaries of the cervix rupture, staining a sticky mucus a pinkish color. The process is called the show or bloody show, and it indicates that labor is about to begin. So if a woman is at work and she like, damn, my mucus plug been broke, um, baby, it's time to go on and tell them, hey, I ain't coming back. I'm out of here. You know, hit them with that SpongeBob picture, cause you on your ass on your way to the goddamn hospital, or you need to chill the fuck out, cause you done worked all the way up. And I'm saying this because I had a girl, that I used to work with, and her mucus plug broke when we was at work, and like a couple of days later, she had that baby. So a mucus plug seals the cervix during pregnancy. Just before labor, the cervix opens slightly and this plug dislodges. At the same time, some capillaries of the cervix rupture, staining the sticky mucus a pinkish color. This process is called the show or bloody show and indicates that labor is about to begin. This is what I will know about show. That is what I will know about show. Okay. True versus false labor. True versus false labor. A pregnant woman may find that distinguishing between true and false labor contractions is difficult. False labor contractions are generally felt low in the abdomen. They occur in irregular patterns and their intensity does not grow substantially with time. Although false labor may be annoying, the contractions come and go. And we know false labors as the Braxton Hicks contractions. So, although those Braxton Hicks contractions, aka the false labor, may be annoying, the contraction come and go. And a change of position or activity can relieve the discomfort. This is what I would know about that. In false labor, no change is found in the cervix or internal examination, and there is no bloody show, meaning the mucus plug hasn't mucus plug is still sealed. However, the pelvic examination itself may dislodge the mucus plug and cause some spotting that resembles show. However, if she get a, when you get close to I think it's like in that close to having the baby. I think it was the 37 weeks when you're going every week until it's time to have the baby. Um, That is when, if the doctor is doing a pelvic examination, the doctor may dislodge the mucus plug and cause some spotting that resembles the show. In true labor, the involuntary uterine contractions are rhythmic, stronger over time. They grow stronger over time. Thank God I ain't never had this shit. And begin the true work of labor. These contractions occur at fairly regular intervals, starting at both 20 to 30 minutes apart and increasing until they are about 2 to 3 minutes apart. True labor contractions usually last about 30 seconds initially and increase in duration as labor progresses. Okay? This is what I would know about all of this right here. It's right here. The interval frequency, I would know this. The interval frequency or time from the labor, well, time from the start of one contraction until the start of the next one in true labor gradually decreases, meaning it gets shorter. Whereas the intensity, the strength and duration, length of each contraction, now that bitch increase. So the bloody show usually appears during this time. This is when the bloody show come about. So we need to know when the bloody show come about. The bloody show is going to come about when the interval frequency or time from the start of the contraction until the start of the next one in true labor gradually decreases, meaning gets shorter, whereas the intensity, the strength and duration length of each contraction increase. This is when that bloody show bitch ass come about. Usually the true labor contraction feels like lower back pain that moves gradually around the abdomen. These contractions help create effacement, 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 which is thinning, and dilation, which is opening of the softened cervix. Okay, so what the contraction is going to do is help create thinning and the opening of the softened cervix. So it creates effacement, which is thinning, and dilation, which is opening of the softened cervix. The most important difference between true and false labor is whether or not the cervix changes during labor. The cervix will become 100% effaced, meaning thin, meaning almost paper thin, and 10 centimeters dilated, which will permit the fetus to pass through it. So, right here in 10 dash, in table 66-1, we're talking about false versus true labor. I would know that that is also in the blue book on page 1047. So it says contractions. No, so false versus true labor. Let's talk about that before I go on. So, and that was it for this paragraph. But false versus true. Contraction is talking about the timing, duration, frequency, intensity, effect of position, or activity change locations were felt. So the timing, irregular space for false labor, and true labor is regular and is rhythmic. I would know this shit right here. Contraction, we're talking about duration. False labor is variable. True labor for duration is increases over time. Contraction, the frequency. False labor is variable, it varies. But in true labor, it becomes stronger. It becomes stronger over time. Intensity. This is the contraction intensity. And the false labor is variable, but in true labor, it becomes stronger over time. Oh, and then frequency, it was variable and it becomes closer over time. And then effects of position or activity change for contraction. False labor, contraction lessens because it all depends on the effect of the position or activity change. That means, you know, you change, you change around, you change your position or whatever, and the contractions may lessen. But in true labor, it becomes stronger with when you get your ass up and walk or when you do activity. So that's how you know, okay, hell no, I'm in labor for real, for real. Contractions, locations were felt. For contractions, locations were felt. False labor will indicate primarily in low abdomen. But a true contraction, well, true labor starts in back and radiates to the abdomen. We need to know all this shit. Cervical change, none. For false, like for the contraction, the cervical change. For the false labor, none. But for true labor, progressive effacement, meaning thinning and dilation. And then for contractions, for presence of show, false labor is none, right? But true labor said is usually present for show. Okay. And they pretty much described all of that for the true versus labor. But this right here, it just breaks it down on the chart and it makes it so much easier for us to understand. So I would look at that. I would make index cards out of something like that, for those of you who need to make index cards. Um, Now let's talk about this uterine contractions. Give me 1 second. So with uterine contraction, contractions of the uterine muscles brings about the birth of the fetus. The uterine muscle is a smooth muscle and the contractions are involuntary. Therefore, the woman cannot hurry, she cannot slow, lengthen, or shorten. So the woman, she doesn't have control over the contractions. She can't hurry them, she can't slow them, she can't lengthen them or shorten them. So if a question like this come on the test, it'll be something like, uh, the nurse knows that the woman may need further teaching when she says she can hurry her contractions, she can slow them, she can lengthen them or shorten them. You know, I would put a question on there like that if I was a teacher. So contractions of the uterine muscle brings about the birth of the fetus, the contraction, and that's what we need to know about contraction. Contraction of the uterine muscle brings about the birth of the fetus. Okay, so during each contraction, the muscle fibers of the uterus tighten. When the contraction ends and the uterus is at rest, the muscle remains slightly shorter than when it started. This is called retraction of the muscles. At this process, as this process continues over the hours of labor, the shorter muscle pull against the point of least resistance or the cervix and cause thinning, which is effacement, and later dilation. The pressure from the top bag of waters or the presenting part of the fetus helps maintain the dilation of the cervix. The pressure from the top bag of waters or the presentating part of the fetus helps maintain the dilation of the cervix. Each labor contractions has three phases. This is what we need to know. Increment, this phase during which the contraction builds from the resting phase to full strength is longer than the other two combined. Increment, the phase, well, this phase during which the contraction builds from the resting phase to full strength is longer than the other two combined. Then you got asthmy or asthmy. This is the time during which the contraction is at full intensity. Think about when I'm looking at that word, and that's basically like, remember in like the Looney Tune commercials they used to have the Ask Me or Ace Me bombs, if I'm pronouncing it right. So just know this is full intensity. So it's like the bomb that blew up, and it intensifies. The damage is intense. So this phase becomes longer as labor progresses. For the acne, this is the time during which the contraction is at full intent. This phase becomes longer as labor progresses. Then decrement, this during this phase, the uterine contraction eases until the resting state is achieved. And that's yeah, decrement. During this phase, the uterine contraction eases until the resting state is achieved. The time between contraction is called the relaxation time or rest intervals, and is equally as important as the contractions themselves. I would know that. So, what is the time called when there's no contraction, relaxation, or rest intervals, and is equally important as the contraction themselves? If the relaxation time is short or absent, the fetus may suffer from lack of oxygen, and the woman may become extremely tired because there's a lack of oxygen going on. So, this is what we need to know about this. We need to know all of this. This one right here. You definitely need to know the uterine contractions and the labor contraction in the three phases: the increment, the acne, and the decrement. Um, but we definitely need to know that if the relaxation time is short or absent, this is so doggone important. The fetus may refer, I'm talking may refer, the fetus may suffer from lack of oxygen and the woman may become extremely tired. Nursing alert. Report immediately if contractions come more than often. Then repeat shit. Report immediately if contractions come more often than every 2 minutes or if each contraction lasts 90 seconds or longer. The rationale behind that is there is not enough relaxation time for the fetus to, be well oxygenated. Therefore, um, shit, why I'm at damn fucking whatever that bug. This is not enough relaxation time for the fetus to be well oxygenated. This event is rare during normal labor, but must be carefully watched for when oxy- oxytocin is used for labor, augmentation, or induction. Notice, know that, know it just like that. Nursing alert. Report immediately if contractions come more than every 2 minutes or if each contraction lasts 90 seconds or longer. Rationale: there is not enough relaxation time for the fetus to be well oxygenated. This event is rare during labor, but must be carefully watched for when oxytocin is um, used for labor, augmentation, or induction. Some people refer to contractions as labor pains. When giving nursing care, the term contraction is preferred to avoid reinforcing the idea of pain. So we're not going to say labor pain. We're going to call them contraction. You may inform the client that she may feel some discomfort and prepare her for the experience. I'm not going to say, "Oh, you finna be in pain, ho," but I'm gonna say you're gonna have some discomfort, and I need you to prepare. We're gonna get you prepared for the experience, okay? That's how the fuck we talk to. We don't want to tell him no pain, and now boom, here go the motherfucking anxiety and crying and all that other shit. However, if she insists that she is in pain, do not ignore or correct her. If she is in pain, we're not going to say, no, there, dear. No, no, no. It's actually discomfort. Hell no. You listen to her. You do not ignore your patient. Instead, work with her on ways to relieve the pain. Such methods may include relaxation techniques, breathing techniques, vocalization, and the use of pain medication. Okay? Special consideration, culture, and ethnicity, expression of pain during labor and births. Among most Native Americans, stoicism, oh shit, what that is, stoicism is encouraged and practiced in childbirth in African American cultures. The expression of pain can be quiet, well, can be quite open in public. Okay, so what the fuck that's supposed to mean? When it's, I guess, quite open in public, I guess we gonna let them know, hey baby, this shit hurt. I guess that's what the fuck they mean. Expression of pain. I'm gonna let your ass know, goddamn it, I'm hurt. Yeah, because we're talking about expression. And just like I'm saying, the African Americans, not all, but some of our ass gonna keep motherfucking 100. And we're gonna let the doctor know, hey, baby, hey, big dog, shit, you ain't got no motherfucking pain meds. What the fuck can you give me? Because oh, hell no. That is the American, or what the African American culture. We're gonna let your ass know. And like I said, among most Native Americans, stoicism is encouraged and practiced in childbirth. So let me look up that word. I guess they ask, they fight that damn pain out. They weather the storm. They stay calm. I think that's what that means the way I'm reading it. But let's see, because it could be something else. They might go out like our black ass, our African American ass. Let's see. It means, yep, patience, the endurance of pain on hardship, or hardship without the display of feelings. Yeah, they some baby, them natives like ain't that. Baby, them natives some strong ass women, but us black women say, baby, say, big dog, come give me some, goddamn it. You know, that's how the African Americans do. Rupture of the membranes. The fetus lies in a two-layered sac filled with amniotic fluid, commonly called the bags of waters. Okay, the fetus lies in two-layered membrane sac filled with amniotic fluid, commonly called the bags of water. I would know that. By the pregnancy 40th week, the amniotic fluid volume has reached approximately 1,000 milliliters, about 1 quart. We learned that in the last in chapter 65. Before the birth of the fetus, the membrane breaks and the fluid is released. It is if left to nature. This usually happens just before delivery and provides additional protection for the fetal head during labor by serving as a dilating wedge against the opening cervix. Okay. So, if left to nature, this usually happens just before delivery. Well, let me go back up here and know what I'm talking about. Before the birth of the fetus, the membrane breaks and the fluid is released. If left to nature, this usually happens just before delivery and provides additional protection for the head, the fetal head during labor by serving as a dilating wedge against the opening cervix. When the membrane breaks, either a sudden gush or a gentle trickle of fluid results. The breaking of the bag of waters without medical intervention is termed spontaneous rupture of membranes and occurs in approximately 25% of all births. Once again, the breaking of the bag of the waters without medical intervention is termed spontaneous rupture of membrane, SROM. I would know that, and occurs in approximately 25% of all births. Even after rupture of the membranes, more amniotic fluid is produced. The stories of dry births are best categorized as myths. So babies not going to come out dry. It's fucked. Babies come out wet. Okay. Even after ruptures of membranes, more amniotic fluid is produced. Although the membrane has ruptured, and more amniotic fluids is produced. So the stories of a dry ass birth, that shit is more like a myth. In the remaining 75% of births, the birth attendant may perform artificial ruptures of membrane. That's AROM. Do not get that bitch mixed up with active range of motion. So, in the remaining 75% of births, the birth attendant may perform artificial rupture of the membranes. Artificial. So, a procedure called amniotomy. This procedure is performed using a special hook, which is an amnio hook, under sterile condition. This procedure may stimulate true labor to begin or may speed the active labor process. So I would definitely know about all of these. Do not get AROM mixed up with active range of motion. That is artificial rupture of membrane. And in the remaining 75% of births, the birth attendant may perform artificial rupture of membranes, AROM. But in spontaneous rupture of membranes, that means, it did it on its own. But in artificial, they caused it. Because think of artificial, when you think of artificial, think of amniotomy or amnio hook. Nursing alert to remember, report any yellow, green, or cloudy amniotic fluid. Normal amniotic, oh, know this shit. Normal amniotic fluid is clear and colorless and has a slightly salty odor. Yellow or green may indicate the fetus has passed uh, meconium stool, meaning they didn't shit it. Not passed like they did, but they didn't shit it while still in the uterus. White or cloudy fluid may indicate the presence of pus in response to an infection. So if the amniotic fluid is white or cloudy looking, it's an infection in there. If it's yellow or green, That baby done shit it off up in there. Okay. And normal amniotic fluid is just clear and colorless, and it got this salty smell. It got a salty odor. And know that. So a simple test known as the nitrogen test will determine if the amniotic sac has ruptured. A strip of nitrogen paper is placed against the client's vaginal wall and is compared with a color standard. The normal pH of vagina is 5.0. That means it's acidic. The pH of the amniotic fluid is 7.0 to 7.5, neutral to slightly alkaline. If the paper, if the paper turns blue, it is probably stained with amniotic fluid, indicating the amniotic sac has ruptured. If the test or urine strip remains yellow, it is probably in contact with vaginal secretion only. Blood or urine may also turn the paper blue. So it is important to avoid touching these body fluids with the paper when providing nursing care to a woman. So know this. I'll definitely know that. So I'm gonna read that again. A simple test known as a nitrogen test will determine if the amniotic sac has ruptured. A strip of nitrogen paper is placed against the client's vaginal wall and is compared with a color standard. The normal pH of the vagina is 5.0, which is acidic. The pH of the amniotic fluid is 7.0 to 7.5, neutral to slightly alkaline. If the paper turns blue, it is probably stained with amniotic fluid, indicating the amniotic sac has ruptured. If the test or urine strip remains yellow, it is probably in contact with vaginal secretion only. Blood or urine may also turn the paper blue, so it is important to avoid touching these body fluids with the paper. So know that right there. Also, so when providing nursing care to a woman whose membrane have ruptured, record the time, method of rupture for the SROM or the which is the spontaneous rupture of the membrane or artificial rupture of the membrane, color of fluid, and the fetal heart rate. When the membranes are ruptured, microorganisms from the vagin, well, I'm talking about vagin, from the vagina can travel through the cervix and into the uterus, which possesses a risk of infection to both the mother and infant. So I would definitely know that. So hold on, because I had to press pause. So I was somewhere up in here. So just know, I know I read that. When the membranes are ruptured, microorganisms from the vagina can travel through the cervix and into the uterus, which possesses a risk of infection to both the mother and the infant. So know that. For this reason, the nurse should obtain a baseline maternal temperature at the time the bag of waters rupture and continue to assess the woman's temperature every 2 hours until delivery. I would know all of that. That's what you need to know. You need to know why we're going to check baseline maternal temperature, because when the membrane is ruptured, microorganisms from the from the vagina can travel through the cervix and into the uterus, which possesses a risk of infection to both the mother and the infant. So you're gonna do that every 2 hours until delivery. This is what you need to know. Check that temperature every 2 hours. If you checked it at 12 o'clock, we're gonna go back in that bitch and check it at 2 o'clock. If the woman's temperature begins to increase, the practitioner will usually initiate measures to prevent infection to the fetus. These measures may include giving IV antibiotic to the mother and planning the immediate delivery of the infant. So we're going to report. That's what we're going to do. We're going to report if we see that antibiotic, I mean, that the temperature start to rise. We don't initiate the antibiotic. We let the physician know, and the physician is going to, uh, order us to give an IV antibiotic to the mother. Okay. So go up here. So we mentioned something about Latin and active and traditional. Let's see. What did I? Okay, so let's read this first. And then we're going to discuss that. Let me see. I'm in my book. Yep, let's discuss that first. Yep, let's discuss that. Let's read this first and then we'll go over the chart because I'm not seeing it over here nowhere. So the practitioner will also assess the fetal heart rate for the possibility of a prolapsed cord. That means that the cord presenting before the fetal head. The cord is presenting before the fetal head. So the practitioner will also assess the fetal heart rate for a possibility of a prolapse cord if the presenting part is not engaged at the time of the membrane's rupture. If there is any questions about whether the presenting part is engaged, a woman who was ambulatory should be placed on bed rest. Providers differ in their practices regarding ambulation for a woman with ruptured membrane when the fetus is of normal size, cephalic uh, presentation, and engaged. In this instance, there is little risk of cord prolapse and ambulation may be permitted or encouraged. The healthcare facility policies and the woman's practitioner provide individual guideline regarding activity. Stages of labor. The entire labor process lasts on average between 8 and 18 hours for the first time mother giving birth. That's prima gravida. It's her first time. And between 1 and 14 hours for multi gravida. So 8 to 18 hours when it's your first baby. And then after that, that bitch, your second baby or the third baby or the fourth, not the fifth one, but if you just had more than one baby, um, about 1 to 14 hours. There are four stages of labor. Stage one is dilation, stage two is expulsion, stage three is placental, and stage four is recovery. Now, with stage one, which is dilation, stage one begins with the onset of true labor contraction and ends with complete cervical thinning and dilation. What the hell? I thought I went over this shit. Let me see. Give me a second. I thought we went over that. Oh, four stages of labor. And what this one talking about? Stages of labor. Shit, we talking about the shit again. So, stage one dilation. Stage one begins with the onset of true labor contractions and ends with complete cervical effacement and dilation. This stage is divided into three phases: Latin, active, and transitional. So that's going to be up here, and we're going to go over there in a second. Stage one can begin with the spontaneous rupture of the membrane, that means breaking of the bag of waters, and uterine muscle contractions with increasing strain and frequency to supply the pressure needed for cervical stretching and dilating. That's what's going on in stage one. Two distinct cervical changes occur during stage one: effacement and dilation. This is what we need to know. What's going to occur during stage one: effacement and dilation. That's the thinning of the cervix. So it begins with the onset of true labor contraction. It's true labor contraction. What we also said can happen, it was called uh it's somewhere the S. It's over the S. Show. Show. It only happens in true labor. So this stage is divided into three phases: Latin, active, and transitional. Stage one, which is dilation is going to be divided into three phases, which we know is Latin, active, and transitional. And that's up here. So let's go over that real fast because this is a chart by itself before we get on to stage two. Well, let's finish reading, then we'll go over it. So, two distinct cervical changes occur during stage one, that's effacement and dilation. Effacement refers to the thinning of the cervix. The cervix, normally long and thick, approximately 1 to 2 centimeters in length, shortens or thin as a result of contraction. This thinning is measured in percentage. The higher the percentage, the thinner or shorter the cervix. Complete effacement is known as 100% effaced, which describes a cervix that has become almost paper thin. In dilation, the cervical OS, the cervical os, which is the opening, normally held closed in tight circle, begins to open. Dilation is measured in centimeters from 1 to 10. Complete dilation, 10 centimeter or about 3.9 inches, is necessary to allow the uterus to expel the fetus. This is what we need to know about that. Cervical dilation is a result of uterine contraction. So complete dilation, 10 centimeters or about 3.9 inches, is necessary to allow the uterus to expel the fetus. Cervical dilation is the result of uterine contraction. Medical personnel are able to estimate the amount of dilation and effacement by feeling the cervix during a rectal or sterile vaginal examination. In the woman, this is her first time about to have a baby, first pregnancy. Effacement usually occurs first, then dilation. That means the thinning of the cervix and then dilation of the cervix come about. In a multi-gravida, effacement and dilation occurs simultaneously. So that means it occurs at the same time. So let's go up here real fast. Average time frames of labor. Average time frames of labor. This is the first time she's having a baby. This is the person that's had the baby here, and she done had more than one baby. It's her first baby. So stage one, Latin, average 9 hours, upper normal 20 hours. Okay. For multi-para, that was for nullipara in the stage one. I don't think we need to know this. Mm-mm. I might learn it though. 'Cause that's too many fucking numbers. And multi-para, you got 5 hours to 14 hours. Stage one, active phase, you got 6 hours. Upper normal is 12 to 12 hours. And para stage one active phase is 2.5 hours to 6 hours. In stage three, you got stage one transitional phase. This is 1 hour. Upper normal is 2 hours. Multi-para is 15 minutes. Upper para is 1 hour. Stage two, you got 1 hour to 2 hours. What 1 hour for average, 2 hours in upper normal for newly para. And stage two for multi-para average is 15 minutes. Upper normal is 15 hours. I would know that. I would. Okay. Um, Also phases of stage one. Like you said, Latin active transitional. Frequency of contraction in Latin is 5 to 20 minutes. Also in Latin phase, it says duration of contraction is going to be anywhere from between 30 to 50 seconds. Character and the intensity of contraction is the regular amount for Latin. And cervical dilation is 0 to 4 centimeters in Latin. Mother's behavior follows direction, excited, she's talkative. Active, frequency of contraction. So that's 2 to 4 minutes. Duration of contraction is 45 to 60 seconds. The character and intensity of contraction is regular, moderate to strong. Cervical dilation is 4 to 8 centimeters. The mother behavior, she's serious to the motherfucker now, and she's apprehensive. She is serious to the motherfucker because that shit didn't it didn't got activated. God damn it, it's active. And then the phase transitional frequency of contraction is 2 to 3 minutes. Duration of contraction is anywhere from between 60 to 90 seconds for transitional. And for character and intensity of contraction for transitional, regular and that bitch strong than a motherfucker. It is very strong. And cervical dilation for transitional, 8 to 10 centimeters. The mother behavior, difficult following directions, frustrated, irritable. She don't want to talk. She ain't got shit to say. She like really fuck your ass. Like I don't give a fuck. She's not paying attention because she is hurting in transitional. So mother's behavior, difficult following directions. She frustrated because she about to get her motherfucking 380 and start blasting on everybody in the goddamn room in transitional. She irritable than a motherfucker. 8 to 10 centimeters. 60 to 90 seconds. That shit going on every 2 to 3 minutes. That shit strong than a motherfucker in transitional. Okay. Two distinct cervical changes. I think I read that. Yep, I read that. So, key concept to remember: effacement of the cervix is expressed in percentage. Full effacement is 100%. Dilation is expressed in centimeters according to the diameter of the um, cervical opening. Complete dilation is 10 centimeters. I would know that whole thing. Key concept to remember: the thinning of the cervix, effacement of the cervix is expressed in percentage. Full thinning is 100%. I keep saying thinning because that's what that means. Dilation is expressed in centimeters according to the diameter of the cervical opening. Complete dilation is 10 centimeters. Now, let's talk about this stage two expulsion. Stage two, which is expulsion. Stage two begins with complete cervical effacement and dilation and ends with the expulsion of the fetus. It lasts about 1 to 2 hours for a prima gravida and usually about 25 minutes for a multigravida, but, but can take as long as 1 hour. That's about 10 to 15 contractions. During this stage, the woman's abdominal muscle and diaphragm join the uterine muscles to push the newborn out of the woman's body. The woman may say she feels pushing pain or a bearing down feeling. The rectum dilates, the perineum bulges, and the top of the fetal appears. This is known as crowning. It's known as crowning. An explosive grunt from the woman as she exhales is a classic sign of stage two. So let's read that shit again. During this stage, the woman's abdominal muscle and diaphragm join the uterine muscle to push the baby out. So she, push the baby out of the push the newborn out of the woman's body. The woman may say she feels pushing pain or a bearing down feeling. The rectum dilates, the perineum bulges, and the top of the fetal head appears. This is known as the crowning. Okay, just know that. An expulsion grunt like, ugh, ugh. Y'all know what the shit sound like if you had to push your baby out. Now I don't know what the fuck that shit sound like because I ain't had to do that. Anyway, an explosive grunt from the woman as she exhales is a classic sign of stage two. Now I grunt when I gotta take me a nice ass shit. So that's what basically grunting is when you pushing. So the birth of the newborn in a normal presentation involves the birth of the head with the face downward. The head then immediately rotates to one side. The shoulders are the shoulders are born one at a time. So both of them fucking shoulders ain't coming out their little ass pussy hole. You got one shoulder come out, bloop, then the other shoulder come out, bloop, and the rest of the newborn follows quickly. The birth of the body ends the second stage of labor. The cord is clamped in two phases and cut between the clamps. Okay, so that's what's going on in the stage two, the expulsion. We're getting that baby up out that cooler cat. So stage three, placental. Placental is stage three. Stage three extends from the time the newborn is delivered until the placenta membrane or expelled. The placenta is attached to the uterine wall after the newborn is delivered. The uterine muscle contracts. With this contraction, the uterus becomes much smaller in size and the placenta is sheared away from the wall and then expelled. Stage three can last as long as 30 minutes for a primary gravida, but usually takes only 5 to 15 minutes for either the primary gravida and multigravida. The placenta is delivered after the uterus contracts. With the contraction, the uterus rises into the abdomen and becomes round or globular. As the placenta becomes in what moves into the vagina, the umbilical cord lengthens, and there may be a sudden trickle or gush of blood. The birth attendant or the nurse keeps a hand firmly over the empty uterus until it feels firm and hard, indicating that the muscles and the blood vessels are contracted and minimal danger of hemorrhage exists. If the placenta is expelled with the shiny membrane side out, it is called the Schultz presentation, And it helps to remember this as shiny shows, okay? Say shiny shows. That's if the placenta is expelled with the shiny membranes. We're going to call it the shiny shows. This is the fetal side of the placenta. Schultz presentation occurs in approximately 80% of birth. If the placenta is expelled with the dual side out, it is called a Duncan presentation. So that's dirty Duncan. Dirty Duncan. This is maternal side, which is rough and irregular. Excessive bleeding is more likely with this type of placenta presentation. I would know these. I would know this. This is something I would definitely know. Dirty Duncan and Shiny Schultz. Dirty Duncan, that shit ain't right. That shit ain't right. It's excessive bleeding, and it's more likely to happen with the Dirty Duncan. In 80% of births, the Shiny Schultz. Okay, that's what we want to see. So the first birth attendant examines the expelled placenta and membrane to determine if the placenta is intact, retained placental fragments, or a major cause of hemorrhage following delivery. The birth attendant also examines the cervix, vagina, and perineum, and then sutures the episiotomy if performed, or any laceration. Blood loss during a normal delivery is usually estimated to be 300 to 350 milligrams. I would know that. I would know that. How much blood is going to be lost? About 300 to 350 milliliters. I think I said milligrams at first. I meant milliliters. And then stage four recovery. Stage four recovery. Go back and look at, we definitely going to look at them bitches like a few more times. I'm going to read this shit again tomorrow. Listen to it again tonight. So, stage four recovery. Stage four includes the first 1 to 4 hours following the expulsion of the placenta. During this time, the woman body, the woman's body begins the process of involution as her reproductive organs begin to return to their normal pre-pregnant size. The total involution takes about 6 weeks. So during stage four, the nurse must closely observe for signs of hemorrhage, urinary retention, hypotension, and undesirable side effects from anesthesia. So this is what we need to know because this is what we're doing as the nurse. This is the implementation. This is what we're going to do as the nurse. We're going to closely observe for signs of hemorrhaging, urinary retention, hypotension, and undesirable side effects from anesthesia. The critical event of this stage is bonding, attachment between the parent and infant. The more time the mother, baby, and other family members spend together during this time, the better the chance of good parental infant attachment. Bonding is important to the development of a solid relationship between the parent and infant. That's a 66 4. We can see that. So we're 66 4. That's 66 2. That's the bonding. I don't know why they do old girl like that and got her mama on the side of the bed, but her baby daddy, he there. He there. Okay. In class alert. Common questions on nursing examinations relate to nursing care and intervention necessarily for each stage of labor. So it's important to know nursing alerts because if they're saying this is what's going to be on the NCLEX, this is probably what's going to be on our test in class. So common questions on nursing examinations relate to the nursing care, what the fuck we gonna do, and the intervention necessary for each stage of labor. So they're telling you right there, we need to know what are we going to do in each stage of labor, and shit, what are we gonna do? God damn it! As far as the care and the intervention, so it's the same damn thing here. So nursing care during labor, nursing care during stage one, maternal care and maternal comfort and care. For this stage, stage one, nursing care focuses on frequent monitoring of the woman's vital sign, contractions, and cervical change, as well as the fetus well being to ensure the safety of both. The findings help the birth attendant to determine the fetus condition and woman's progress. Of equal importance is the role of the nurse in the physical and emotional support of the woman. Like I told you, care and intervention. Admission procedures for women in labor vary among healthcare facilities. However, the important elements of an admission history are standard in all institutions. The admitting nurse asks about the estimate date of delivery, which is the EDD, which we learned in chapter 65, and confirms this by comparing the information obtained with the prenatal record, which may already be on file at the hospital or may be brought by the woman. If the newborn is preterm, special precautions are taken, and special, that means it's coming before the full term. Special equipment is ready. The nurse also obtains the following information: when labor begins, how close the contractions are, how long each contraction lasts, whether the client has noticed any bleeding, whether the bag of water has ruptured. This is what we would know. I think this is important to know. What information are we going to obtain from the woman during admission? When the labor began, how close the contractions are, how long each contraction lasts, whether the client has noticed any bleeding, whether the bag of water has ruptured. The anesthesiologist or certified registered nurse, anesthetist, CRNA, will also want to know when the client last ate. I need to know when you last ate, okay, before I give you this goddamn that's the CNR, the anesthesiologist, okay? Oh, they make some money too. This is just showing the normal birth process. The baby head came out. It would have been one shoulder, then the second shoulder, then boom, stinking ass baby came out. The normal birth process. Okay, so anyway, nursing alert. Know this nursing alert. Report any bright red bleeding at once. Rationale: a client who is bleeding should never be examined vaginally until ultrasound rules out placenta previa. Okay? Report any bright red bleeding at once. The rationale behind that is a client who is bleeding should never be examined vaginally until ultrasound rules out placenta previa. Other routine procedures include checking temperature, post respiration, and post blood pressure blood pressure, urine dipstick testing for sugar and albumin, and blood tests for hemoglobin, hematocrit, and confirmation of the mother's blood type. The fetal heart tone should first be checked at the time of admission. The birth attendant may examine, we need to know that the fetal heart tone, when should they be checked? At the time of admission. The birth attendant may examine the woman's heart, lungs, and abdomen and will also listen to the fetal heartbeat. In most facilities, an external fetal monitor is applied to the woman's abdomen to obtain a baseline fetal heart rate tracing. A sterile vaginal examination often determines how far labor has progressed. Nursing alert to know: be sure to ask the woman upon admission about allergies to povidone iodine, betadine, lidocaine, um, xylocaine, or any other drugs in latex. Rationale: allergic reaction can range from uncomfortable to fatal. So be sure to ask if she got betadine, lidocaine, or latex. So there's xylocaine, betadine, and latex. Because we don't need no allergic reaction coming about. Remember to keep the woman and her partner informed of progress and to observe closely at all times for any signs of fetal distress. So in this box, danger signs of labor, you gotta, report any of these signs to a team leader immediately. So know that. Know that we're gonna report these signs. If they got sharp, unremitting pain, prolonged contraction or failure of the uterus to relax, rigid uterus after a contraction. Remember what we said about prolonged contraction, or um, the contraction isn't resting, meaning the oxygen is not, the baby isn't getting oxygen and the mother's going to become tired. Change in character of the fetal heartbeat, abnormal deceleration, pattern of fetal monitor. So change in character of the fetal heart rate, abnormal deceleration, pattern or fetal monitor on fetal monitor, so that baby heart rate probably is slowing down. Maternal bleeding. extreme maternal exhaustion. So if she's exhausted, that's because there's something going on, probably with the oxygen. Cessation of labor after it has begun. So that means the labor has stopped after it has begun. Hypertension or increased pulse rate of the mother, maybe losing some blood. Prolapse of umbilical cord. That means the cord came out first. Irregular fetal heartbeat. Either is extreme shit, just no normal heart rate. Heartbeat is between 120 to 160. Passage of meconium stained amniotic fluid. Fetus is in the vertex when fetus is in the vertex position. So meconium stained amniotic fluid. I think that was that yellow and brown color, which is shit. And if it was no, it's yellow and green. And if it's white cloudy, that means that's an infection. Because amniotic fluid is always clear. It's clear and it has a salty odor. And exaggerated movement of the fetus, like it's just like what the fuck, like it's trying to get the fuck out of there, and it's very exaggerated. Probably too much fucking moving going on. A pH value below 7.2 of fetal blood drawn from scalp vein, indicating fetal acidosis. A pH value below 7.2, because I think it was like 7 point, let me go back up, 7 point, it's up some more. Which one was it? This one you put that. Shit. It was way up. I don't think it was way up here. Oh, yeah. 7.0 to 7.5 is neutral, slightly alkaline. The normal pH of vagina is 5.0. So let's go back down and read that one. It says um, a pH value below 7.2. Okay. Below 7.2 of fetal blood drawn from scalp veins indicating fetal acidosis. Because when it's time to come out, it's really 7.0 to 7.5. But if it's below 7.2, it's something going on. So Uh, we read that all the way down. Let's come back up here. Observation and data gathering. Uterine contractions. This is what we're doing. We're observing and we're gathering data. Uterine contractions are one means of checking progress. A sterile vaginal examination, SVE, usually performed by the midwife, OB, or registered nurse, also assess the labor's progress. In addition to the degree of cervical dilation and effacement, the examiner is able to determine the presenting part, station, size of the pelvic outlet, and status of the membrane. Nursing students may assist by ensuring that the client is draped properly and that the examiner the needed has the needed supplies, sterile gloves, lubricants, and if necessary, an amnio hook. Students should not be asked to perform SVEs if, as a graduate, you are asked to perform an SVE. You must receive in-service instructions in the procedure from the healthcare facility first. Okay, so that is something important to know. Uterine contractions are one means of checking progress, checking progress. I don't know why the fuck I keep saying progress. Progress. A sterile vaginal examination, SVE, usually performed by the midwife, OB, and registered nurse, also assess the labor's progress. In addition to the degree of cervical dilation and thinning, effacement, and that's opening. So opening and thinning, the examiner is able to determine the presenting part, station, size of the pelvic outlet, and the status of the membrane. Nursing students may assist by ensuring that the client is draped properly and that the examiner has the needed supplies like the sterile gloves, the lubricants, and if necessary, an amniotic hood, amnio hood. Students should be asked to perform SVEs. So we should not be asked. I'm sorry. Hell no. We ain't getting up in nobody coochie. looking up in nobody coochie, want know what the fuck we looking for because we ain't even trying to do that. If as a graduate you are asked to perform an SVE, you must receive in-service instruction in the procedure from the healthcare facility first. Okay. Emotional and physical support. Nursing support during stage one is directed towards making a woman as comfortable as possible and encouraging her to do the things like breathing that promotes the normal progression of labor. So you can't tell her how to fuck to breathe in the fourth stage, in the last stage. Teach her how to, do breathing exercises early on. Labor is exactly what it implies hard motherfucking work. In the past, women women were encouraged to be passive during labor, to lie down and rest. More currently thinking is that the woman should be an active participant in the labor process. Now, baby, you need to fucking not like now. Ain't no just lying down and we do all the work. We push the baby out. No, baby, you need to help us. You need to help us get this damn baby up out of you, okay? By laboring. Oh, look at that baby. Is that the baby? That baby don't look like it survived. Oh no. Oh. Labor is exactly what it implies. Hard work in the past, women were encouraged to be passive during labor, to lie down and rest. More current, more current thinking is that the woman should be an active participant in the labor process by laboring in different positions, walking or even showering during labor. The healthy woman is more likely to have a normal progression of her labor. I gotta see. Oh, that baby didn't make it. That look like a preemie. Mm. I'm looking at the way the baby look. I don't think that baby developed. Oh, poor baby, poor woman. That's why she look like that. They talking about bonding. They know that baby gone. Okay, so special consideration, culture and ethnicity, activity during labor. Traditional Puerto Rican women prefer being in bed for labor, whereas Haitian women may walk, pace, sit, squat, and rub their bellies. Samoan women may be either active or passive as they prefer. Many West Indian women continue with housework during early stages of labor. So they folding up clothes, they cooking and shit, you know, um, cleaning. That's what those West Indian women are doing. Carefully observe the client physical state during labor and delivery. Measure and record her vital signs at least every 4 hours and the fetal heart tones at regular intervals. Follow healthcare facility routines careful motherfucking. Stay with the client and do everything possible to help her work with the contraction and relax and rest between them. Encourage the father or support person to be as involved as the couple wishes. Remind the woman to breathe slowly and deeply and to use any techniques learned in childbirth preparation class to relax her muscles and allow the contraction to do the work. Sponge the woman's face and hands occasionally. Rub her back. Offer her a sip of water or ice chips from time to time. Change her. Change her gown or bedding if they become damp or soil. And see that the air in the room is fresh. Who want to give a baby in a funky ass room, sweating and shit? You know what I'm saying? With a dry ass mouth. Special consideration, culture and ethnicity, environmental consideration. Philippine women may want noise and stimulation minimized for fear that too much commotion will increase labor pain. I'm with you on that, baby. Ensure that the client bladder is empty. So you want to make sure that she don't went and piss. So when she's, pushing the baby out, she don't piss on everybody in the damn room. A full bladder prevents the fetal head from descending into the woman's pelvis and thereby slows labor progress. So that is something important to know. A full bladder prevents the fetal head from descending into the woman's pelvic and thereby slows labor progress. So it's going to descend because the bladder is going to be blocking. So go on and go pee. You don't want the bladder blocking the fetal head. A full bladder during labor may also result in trauma. urinary incontinence during delivery, or urinary retention in the immediate postpartum period, in which case catheterization may become necessary. So this all is important right there. That's something that may be on the test. Early labor is best spent out of the bed. The healthy woman may choose to walk, sit in a rocking chair, shower, or engage in diversionary um, activities such as card games or conversations. Like if I did have some labor early on, I don't know, we probably would have been playing Uno because I didn't know how to play spades then. So early on, have the woman to walk, sit in a rocking chair, shower, get that cooler cat clean because I don't want you be up in their face. They trying to deliver your baby and your pussy stink. And engage in divisionary activities such as card games or conversation. As the labor becomes more intense, she will concentrate more and more on the contractions and may have little tolerance for suggestions that she earlier would have welcomed. For those times when the woman is in bed, she might prefer to have the head of the bed elevated. If she does flat, if she does lie flat, however, she should lie on her left side. We already talked about why they shouldn't lie flat, rather than on her back to prevent hypotension, which results from what? The aorta, the compression of the aorta and the vena cava by the weight of the uterus falling backwards against the spine. We learned that in chapter 65. Some hospitals allow the woman, some hospitals allow the woman to be ambulatory only as long as the bag of water is intact. Other hospitals allow a woman whose membrane have ruptured to be up and about if the fetal presenting part is well applied to the cervix. Be sure to know and follow the policy of the institution and the woman's birth attendant. Water and clear fluids are usually allowed during the very early stage of labor. Some believe that solid foods may cause a woman to vomit, particularly if she is to have a general anesthetic. Others would prefer that the gastric acid be diluted by oral intake, even if a general anesthetic becomes necessary. Okay, so just know that. I would know that. It has become common practice in many hospitals to get IV solution to maintain caloric and fluid intake and to lessen exhaustion and dehydration. I would know that. However, be aware that a full liter bag of 5% dextrose contains only about 125 calories, and if given at a slow infusion rate, will not be sufficient to prevent maternal exhaustion. I would know all that. That's something I would know. So you're not going to give them that old weak ass 5% dextrose that contains only about 125 calories. We're not going to give it to them in a slow infusion because it's not going to be sufficient to prevent maternal exhaustion. Culture and a necessity to remember: food and drink during labor. Offer Korean women lukewarm water, no ice. You know what? I just saw that on YouTube the other day. No, not YouTube, Instagram. And I saved it. I'm going to send a video out. For Korean women, you do not give them no motherfucking ice. It was on Lovely Mimi page. You do not give them ice. That's just traditional because they believe it causes hemorrhaging. So you don't give Korean women ice. You give them lukewarm water. No ice should be given in order to maintain the balance between hot and cold. This balance is also known as precarious during labor in Vietnamese women. Most South Asian women encourage light meals during labor. Let me send it to y'all now. So, for the relief of discomfort, if the client desires after labor is well established, and she may be given medications to make her more comfortable and relaxed because we're trying to, give her something to relieve that discomfort. So the type of drugs may vary with the locale and provider and the woman's condition. Analgesics reduce the discomfort of labor. Sedatives promote rest, and tranquilizers relax the client. Sometimes a combo of two drugs is administered. Antiemetics may also be given for women who experience nausea or vomiting during labor. Nursing alert: after consulting with her provider, a woman often makes a decision about when to use medication during labor. Rationale behind that is medications may slow labor if given too early or may cause the newborn to be lethargic if given too late. So remember that, remember that, remember that, remember that. Okay. Now, many clients receive some forms of anesthesia during labor and delivery. One of the most common, everybody motherfucking know about this, is the epidural anesthesia, also called the lumbar epidural block. A small catheter is inserted into the epidural space within the spinal column. The catheter is taped into place, and a test dose of the anesthetic drug is given. If no undesirable side effects arise, the drug can be carefully administered through the catheter during labor and delivery, either intermittently or continuously using a pump. Most women receive pain relief within 20 minutes, and anesthesiologists should monitor the administration of this type of anesthesia becoming well because serious side effects like maternal hypertension can occur. The woman receiving epidural anesthesia during labor should be positioned on her side with her head slightly raised. If she lies on her back, a small firm pillow should be placed under her right hip so that the uterus tilts to the left. This measure will help prevent the compression of the woman's aorta and vena cava. Monitor the woman's blood pressure frequently, at least every 15 minutes. The fetal heart rate should be monitored either continuously with an electronic monitor or frequently with a fetal scope. Disadvantage of delivery using epidural anesthesia include the blocking of the urge to push in stage 2 and an increased chance of forceps delivery. And forceps delivery is, because y'all, we got to know about, if we don't know what the fuck shit means, we look it up. Forceps delivery, and Google said that this is is a type of assisted vaginal delivery. It's sometimes needed in the course of vaginal support. In a forceps delivery, a healthcare provider applies forceps which is an instrument shaped like a pair of large spoons or salad tongs to the baby's head to help guide the baby out at the birth canal. Okay? Y'all know what that look like. Like you pulling the baby out with some goddamn salad tongs. Other anesthetics can be injected into the spinal canal, which is saddle block, the caudal space, which is the caudal block, or the pseudodenal, which pseudodenal. I think that's pseudo. I think that's silent. Pseudodenal nerve, which is the pseudodenal block. Sometimes the local anesthetics is injected around the cervix, cervical block. Although the client is awake during delivery, she loses sensation in the anesthetized site. The following anesthetic agents are frequently used: tetracaine hydrochloride, which is puntacaine; bupicaine, which is hydrochloride nephrocanal; lidocaine, which is hydrochloride. It's like dilocaine or xylocaine. Remember, we're gonna ask if she's allergic to the motherfucking xylocaine. So I would ask if she's allergic to any of that shit. So general anesthesia is rarely used because the client receiving this type of anesthesia is asleep when the newborn arrives. Okay, so general anesthesia is going to be rarely used because the client receiving this type of anesthesia is asleep when the newborn arrives. I would know that. Babies born this way may not breathe spontaneously and may be difficult to awaken. I would definitely keep that in mind. General anesthesia is used in emergencies only. Emergency will be like an emergency cesarean delivery because of the possibility of newborn central nervous system depression. Okay, that is something I would know. I would definitely know all of that. In most cesarean deliveries, general anesthesia is not given until after the baby is delivered, with either spinal or epidural anesthesia used before that. Each type of anesthesia has distinct advantages and disadvantages. The client needs and wishes and of the availability of medication dictates the form used. Many women view labor as a natural function and desire to deliver with little or no medication. I ain't if it was up to me, I don't like no motherfucking pain. So I would have hit the bitch with hell no, that ain't me there. Um Nursing alert for the woman receiving anesthesia. Report the following finding immediately: inability to move the legs, numbness in the legs, ringing in the ears, dizziness, metallic taste, hypertension, or seizure. The rationale behind this is the serious side effects of anesthesia can be fatal to the woman and her baby. and or the baby. Okay, so for women receiving anesthesia, report the following findings immediately: inability to move the legs, numbness in the legs, ringing in the ear, dizziness, metallic taste. Because if it's a metallic taste, that may have something to do with the. I think that has something to do with the kidney, and hypertension or seizure. So, assessing fetal well being. The well being of the fetus is the utmost concern during the course of labor. The best indicator of fetal health is the fetal heart rate. We know it is 120 to 106 beats per minute, which is normal for the fetal heart rate. The frequency with each, well, with the fetal heart rate is evaluated should depend on the absence or presence of the risk factors. Fetal heart rate evaluation may be done using a fetal scope to perform intermittent auscultation, and electronic, which is an electronic monitor, may be used for continuing monitor or periodic test strips. Electronic monitors can be used externally or internally to permit internal electronic monitoring. The membrane must be ruptured. Once again, to permit internal electronic monitoring, if they're going to do it internally, the membrane have to be ruptured. So remember that. If they're going to do it internally, internal electronic monitoring, the membrane must rupture. Intermittent auscultation. When there are no risk factors with the mother or the fetus, the standard practice is to evaluate the record, well, evaluate and record the fetal heart rate at least every 30 minutes during stage one. I will know this. This time I will know. And at least every 15 minutes during stage two. When risk factors are present, the fetal heart rate should be evaluated at least every 15 minutes, stage one, and every 5 minutes during stage two. So that's this is the normal versus the abnormal. So the normal would be when everything is going good, I'm gonna monitor the fetal heart rate between 30 minutes during stage one and at least every 15 minutes during stage two. But when it's risk factors, this is abnormal. So the fetal heart rate, I'm going to monitor it every stage. Well, for stage one, every 15 minutes during stage one, and then every 5 minutes during stage two. Now, the key concept to remember, and you need to know that, I will know that. Key concept to remember, the most important factor in the fetal monitoring is the relationship between the heart rate and the contraction of the uterus. Once again, the key concept to remember is the most important factor in fetal monitoring is the relationship between the fetal heart rate and the fetal contraction of the and the contraction of the uterus. The most important factor in fetal monitoring. It's the most important factor. It's the more important thing about um, fetal monitoring is the relationship between the fetal heart rate and the contraction of the uterus. Electronic fetal monitoring, continuous electronic monitoring of the fetal heart rate during labor is routine in many facilities. The purpose of the fetal monitor is to record the rate and quality of the fetal heartbeat during contraction and relaxation. So, what is the purpose of the fetal monitor? We use it because we're going to record the rate and the quality of the fetal heartbeat during contraction and relaxation. It can give an early warning of fetal distress so that corrective measures can be started ASAP. The nurse will periodically print out, meaning we're going to run off strips of the monitor's graphic record and place them into the woman's chart as part of the documentation of labor. Now, remember me in this situation with the electronic fetal monitor. It also is monitoring, like I said, contractions and shit like that and relaxation. And when I was in the hospital, because, I had to have my child early and y'all done heard this shit 1,000 times from me, but hey, you're going to hear it 1,000 times more. But anyway, they had me hooked up to this machine, and the nurse kept running into the room, and she was like, "You don't feel that? You don't feel that?" I'm like, "Feel what?" She was like, "You're having contractions." I said, "Ma'am, I don't feel a damn thing." So, and thank the Lord, I wasn't. So, in electronic fetal, so that's basically what that is. They can see it. They're looking at it at the nurse station. An electronic fetal monitor is usually used in the following situations: if the fetus seems to be in distress, if the delivery is being induced, if the woman has a sharp, I'm talking about, I shouldn't say Shariani, if the woman has a chronic health problem, if a complication of pregnancy exists, okay? An electronic fetal monitor is usually used in situations if the fetus seems to be in distress, if the delivery is being induced, If the woman has a chronic health problem, if a complication of pregnancy exists. Ex- So I would know when are we going to use a fetal monitor for a woman. If the fetus seems to be in distress, if the delivery is being induced, if the woman has a chronic health problem, if a complication of pregnancy exists, I would know that. External monitoring of fetal heart tone is most commonly used. External monitoring of fetal heart tone, that's going to be most commonly used. We mainly use external monitoring rather than internal monitoring. This approach is based on a Doppler effect, and y'all know what a Doppler is, in which high frequency ultrasound waves, we learned that in chapter 65, directed to the health fetal heart bounce back to a transducer strapped onto the woman's abdomen. The receiver amplifies the fetal heart sound. The signal is converted to sounds and is printed on electrocardiograph paper. Those of you who are not familiar with Doppler effect, just look this shit up on YouTube, a Doppler on a mother's, on a pregnant woman's baby or whatever. In addition, a pressure sensitive device called a taco, I'm talking about taco, here, taco, it might be taco dynamometer, taco dynamometer. I probably fucked that all the way up. Is used to monitor the frequency of contractions. I would know that. So what is going to be used to, what is a pressure sensitive device that is used to monitor the frequency of contraction? A taco dynamometer. Okay, I remember that. When placed directly over the woman's fundus, which is the upper curve of the uterus, the device transfers an electrical impulse to the monitor, creating a readout. The toco dynamometer does not give information about the strength of the uterine contraction. The relationship between the fetal heartbeat and uterine contraction can be studied because the information is printed simultaneously, meaning all together. So remember that the toco dynamometer does not give information about the strength of the contraction. We don't know about the strength of the contraction. It is just monitoring the frequency of the contraction. Okay. Advantages of external monitoring or that is non-invasive, has no contraindication, and is easy to apply. Advantages of that external monitoring or that it is non-invasive, it doesn't hurt, has no contraindication. It's just, it's externally, it's on the outside. It's not going to cause any issues. And is easy to apply. Now let me tell you about the disadvantages. The disadvantages of that external meter is it includes the need for frequent adjustment and is sensitive to fetal and maternal movement. Now, if the external monitor printout signals a fetal or maternal problem, an internal or direct monitor is used because it is more accurate. Internal or direct monitor or more accurate. I would know that. If the external monitor printout signals a fetal or maternal problem, an internal or direct monitor is used because it is more accurate. An electrode, such as the scalp clip scalp clip or spiral, is placed through the woman's dilated cervix and carefully attached directly onto the presenting part of the fetus. The internal monitor can provide precise information, including a fetal electrocardiogram. The external sensor may still be used to measure the frequency and length of the uterine contraction, or a catheter, which is an intrauterine pressure catheter, and it may be inserted into the uterus so that the intensity of contractions may be measured. So, the external sensor may still be used to measure the frequency and the length of uterine contraction, or a catheter, which is an intrauterine pressure catheter, may be inserted into the uterus so that the intensity of contractions may be um, may be measured. So I would know this because we already said that an external monitor, it can't tell us about, it doesn't record. External monitors doesn't record um what it said. It doesn't record. Shit, where is it? I just read this shit. Mm, it's somewhere. Basically, the damn external monitors don't do this. That it with external monitors, yeah, they don't measure the intensity of the contraction. So that's going to be done by the intrauterine pressure catheter. The advantages of internal monitoring include a high quality tracing and fewer artifacts, meaning interference from the sources, other sources. So um, the the advantage of internal monitoring include a high quality tracing and fewer artifacts, meaning interference from the sources, other sources, than external monitoring. The disadvantages, though, are that the membrane must be ruptured, the cervix must be dilated, and the presenting part must be accessible. That's the disadvantage. The membrane got to be ruptured, the cervix must be dilated, and the presenting part must be accessible. Evaluation of fetal monitor information. As a nursing student or licensed practical nurse, you most likely will not be responsible for the interpretation of electronic fetal monitoring, so don't worry about that shit. However, what our asses need to know is we need to understand the basic theory and terminology. Notify the team leader immediately if any of the signs of fetal distress appear on the fetal monitor, such as acceleration, deceleration, decreased variability. So basically, if we see acceleration, meaning acceleration or brief increases of the fetal heart rate of 15 beats per minute or more, it is signs of healthy fetus for it is a sign of a healthy fetus for the fetal heart tone to accelerate after movement or stimulation. Any acceleration of 60 beats per minute or more is considered a complication and the fetus may be in danger. I would know this. I would know this. I would know all of this. Okay. And then for deceleration, slowing of the fetal heart rate or is accelerate, when you're pushing on the gas, you're accelerating, decelerating when you're coming up off the gas. So deceleration is the slowing of the I'm talking about VH, of the fetal heart rate or categorized according to when they occur in the relation of the contraction, well, to a contraction. Some decelerations are expected, others are warning signs of possible problem. An early deceleration begins early in the contraction, hits its low point at the peak of the contraction, and returns to baseline at the end of the contraction. It mirrors the contraction pattern. Early decelerations are caused by vagal nerve stimulation, resulting from pressure of the fetal head, and are considered a normal response of the fetus to labor. A late deceleration begins as the contraction eases and lasts longer than the normal contraction into the resting phase of the uterus. This is a sign of a possible problem and should be reported. It should be reported to the team leader. This is what we need to know. We know that early deceleration, that's fine. That's fine. You know what I'm saying? Early deceleration is going to um, begins early in the contraction. It hits its low point at the peak of the contraction and returns to baseline at the end of the contraction. It mirrors the contraction pattern. Early decelerations are caused by um, vaginal, no, I'm sorry, by vagal nerve stimulation resulting from pressure on the fetal head and are considered a normal response to fetus labor. But an abnormal response is a late deceleration begins as the contraction eases and lasts longer than the contraction into the resting phase of the uterus. This is abnormal. This is a sign of a possible problem and should be reported to the motherfucking team leader ASAP. Decreased variability, little to no fluctuation in the fetal heart rate on an internal electronic monitoring tracing is a danger sign and may indicate an abnormality in the fetal nervous system. It might also indicate that the mother has taken or been given central nervous system depressants. Report this observation to the team leader for further evaluation. Once again, decreased variability, little to no fluctuation in the fetal heart rate on an internal electronic monitoring tracing is a danger sign. meaning that the heart rate is it isn't increasing, it's not decreasing, it's not doing, it's just remaining the same. And this can be a danger sign. It may indicate an abnormality in the fetal nervous system. It might also indicate that the mother has taken, she's been given a central nervous system depressant, may have been given that shit too late. So we got to report the observation to the team leader for further evaluation. Now, nursing alert to remember, this is important. Variable deceleration in fetal heart rate occur anytime during or after contraction. They usually indicate umbilical cord compression and can usually be altered by changing the woman's position or by giving her oxygen. Now, late deceleration once again begins late in the contraction, and the fetal heart rate uh, recovery occurs after the contraction is over. Decelerations are related to placental insufficiency and indicate fetal distress. The fetal heart rate should not fall below 100 beats per minute. Know that. And also, especially know that the fetal heart rate should not fall below 100 beats per minute. Let's take a break. So, nursing care during stage two, maternal care, either a LPN or RN will assist in delivery. If you are assigned to assist during the birth, you most likely will help with the transfer of the delivery room in a traditional labor and delivery suit, and then stand at the woman's side, instructing her on how to breathe and when to push, and informing her of what is occurring. If you are assisting the birth attendant, you may be responsible for handing him or her necessary equipment, medication, and other items. If you are caring for the newborn, you will need to make sure that the infant is breathing and kept warm. Aseptic conditions must be maintained during delivery. You and any of the woman's support people will hold on. Aseptic conditions must be maintained during delivery. I would know that. I would definitely know about aseptic conditions. You want to be clean throughout the entire delivery. You and any of the women support people will wear a clean scrub suit, a cap to cover your hair, and a mask. I would know that. What are we going to wear? We're going to wear a clean scrub suit. We're going to wear a cap to cover our hair, and we're going to wear a mask. If the client is going to delivery in a hospital delivery room, she is transferred on her bed and out, moved over to the delivery table with the assistance of the circulating nurses. The table, which is split across the middle, is open, broken, and um, and the woman's buttocks are positioned at the break in the table. Her feet are placed in stirrups simultaneously to prevent strain on the pelvic ligament. Perineal preparation is done to cleanse the skin and to remove secretion from the genitalia. Shaving is rarely done today, though. If you got a wolf pussy down there, you just gonna have a wolf pussy when the baby come out. In some cases, a birthing chair or squat bar is used. Coaching the client. In stage two, the woman actively helps the birth process. As each contraction begins, she takes a deep breath. She holds it and then she pushes with each contraction. Women often makes grunting noises like ugh during pushing. If the woman relaxes between contractions, she can work better when the next contraction comes. Encourage the woman to push only with contractions and to rest between them. Know that it is important to know. If a woman tells you the baby is coming, you should trust her judgment. Get assistance ASAP and check for crowding. If a delivery occurs suddenly without advance warning and aseptic preparation, is called a preceptuous delivery. This is different from a preceptuous labor, in which fewer than 3 hours elapsed from the onset of labor to birth. I would know that. I would know this. A client may precipitate in the labor room bed if her claim that birth is imminent is ignored. Encourage the mother to pant or blow forcefully when told not to push. Remember that only one person should give the woman instruction. During this challenging experience, too many different voices and direction can be overwhelming. Know that. Know that. Episio, epis, oh shit, epiostomy. Often the birth attendant makes an incision in the perineum called an epiostomy. We learned this also in chapter 65, which enlarges the vaginal opening and allows an easier delivery of the fetus. Some birth attendants believe that epiostomy helps to preserve the structure and strength of the perineal muscle and prevents a jagged laceration on a tear extending to the anus. Other birth attendants believe that a laceration, should one occur, will be less extensive than the episiotomy. Extensive lacerations are difficult to repair and could leave permanent damage. Note that the following, note that the type of episiotomy, midline or right or left medial lateral, as well as any lacerations that occur on the woman. So that's in 65, 66-5, that's right here. Position of episiotomy incision in a woman during stage two. The baby's head is presenting to vaginal outlet. So it can be midline or it can be medial lateral. This is the head of the baby finna come out. So position of episiotomy incision in a woman during stage two. The baby head is presenting to the vaginal outlet crowning. So they either gonna cut your ass like that or like that. Oh, wait. Mm. That's the booty. And if you cut that bitch all the way down like that, it's hard for it to heal. I forgot what it was called, but we learned that in um, Women and Men. Um, yeah, we learned that in Med Surge. So neonatal care. After the baby head is delivered, the birth attendant will check for any loosened cords that have become wrapped around the neck of the infant, which is called Nucia cords, and we're going to remove that bitch. Next, he or she will suction the nose and mouth of the newborn with a bulb syringe. The anterior shoulder is delivered, then the posterior shoulder, and the remainder of the body. So it's shoulder, shoulder, then the remainder of the body. The newborn cries like a little bitch, and the lungs expand. The time of delivery of the baby should be noted for the legal records. The entire portion of the delivery often takes only a few seconds. The baby may be handed to the mother immediately before the umbilical cord is clamped. Assist the mother in placing the baby on on the bare skin of her chest. Dry the baby. Remove. Excuse me. Remove. Why am I? Dry the baby. Remove any damp towels or sheets and cover the baby with a clean, dry cloth. Most babies come quickly after experiencing the warmth of the mother and security of her embracing arms. You should observe for the infant's breathing pattern and suction the mouth if needed. When the umbilical cord stops pulsating, two Kelly clamps are applied to it, and the birth attendant of the baby father cuts the cords between them. Okay? When the umbilical cord stops pulsating, two Kelly clamps are applied to it, and the birth attendant or baby father cuts the cord between them. But it have to be when the umbilical cord stops pulsating. So I will remember that. An umbilical clamp is later applied near the baby's abdomen and makes certain it is attached securely, but does not pinch any fold skins. Some as hospitals and birth attendants prefer that the baby that the infant be stabilized first in a radiant warmer. After the newborn is stable, the parent may hold the infant. However, healthcare personnel are responsible for the newborn's care. Newborns must be kept warm, yet should have time to hold and to bond with them. Newborns should be kept warm, yet parents should have time to hold and to bond with them. Overhead warmers allow you to observe the newborn. Observation of the newborn includes assessment of the Apgar score at 1 and 5 minutes of life. We'll learn about that in chapter 67. So, for each delivery, a staff person skilled in neonate resuscitation should be available to provide resuscitation if needed. If the infant is depressed or not fully responsive to stimulation, The neonatal resuscitation expert should be called immediately. I would know this. I would know that. Every minute is critical. Never delay summoning help in the hopes that the baby condition will improve. I would know that whole thing. That whole little paragraph is important. All right. So now we're talking about nursing care during stage. This is where I'm finna take a motherfucking break and I'll finish this shit tomorrow. It's only like 5 pages left. I'm taking a break. Okay, so nursing care during stage three. Stage three is relatively short, but may be dangerous, maybe a dangerous period. Okay, stage three is short, but that bitch got some power behind it. It's dangerous for the mother because of the possibility of hemorrhaging. So she may hemorrhage, or the possibility of hemorrhage. The nurses or the nurse should record the following information about the delivery of the placenta. I think this is important for us to know because this will be our job. You know, I'm not for sure if it's an LPN or a depending on the facility or a registered nurse. But this is important out of this passage. Well, out of this paragraph. The exact time the placenta was delivered, we have to notate that whether the placenta was delivered spontaneously or removed manually. We need to know that. So spontaneously is like the placenta came out on its own or removed manually. We had to pull it out. Or which side of the placenta presented? Was it remember it was the sides we just talked about that. That was um a few minutes. Well, it's up further. So after the placenta is delivered, an oxytocic medication may be administered to assist the uterus to contract and to minimize the risk of bleeding. You may be instructed to administer these oxytocic or to oxytocic or to massage the fundus gently to minimize blood loss. I think this is important to know. Either we're going to give we're going to administer the oxytocin as order, or we're going to massage the fundus to gently minimize blood loss. So the fundus is what we massage to minimize blood loss after the placenta, has been delivered. After the birth attendant has examined the cervix and vagina, inserted the epi. Oh, I keep fucking this word up. Episiostomy to or laceration. The vulva and perineum should be cleansed. If stirred up were used, remove the mother's legs from them. Okay. After the birth attendant has examined the cervix and vagina and sutured the episiostomy or laceration, the vulva and perineum should be cleansed. If stirrups were used, remove the mother's leg from them. Key concept: bring the mother legs down from the stirrups slowly and together. And the rationale is because doing so helps to avoid further trauma and discomfort. So don't move them quickly. Move the legs slowly from the stirrups slowly and together to avoid further trauma and discomfort. Change the woman's gown, apply perineal pads, and cover her with a warm blanket. So, healthcare facilities transfer women to recovery room, what some do, and others, uh, the woman recover in the room where she delivered. Before the woman leaves the delivery or birthing room, complete the necessary documentation, and that will be in box 66-3. So necessary documentation for delivery. I'm going to as a nurse, we're going to complete information about the type of delivery and procedure used and who was present. We're going to document the sex and condition of the baby, include APGAR score, the time of the birth, time at which the placenta was expelled, and presentation indicate manual removal or spontaneous delivery, condition of the fundus, any medications administered, if an episiotomy was done and is type condition, well, if any episiotomy was done and it's type, remember it was like the one that was go straight up and down, and then it was one to the side. It's up further. We'll have to look back over it. I cannot remember it because this is a day later. I put this video on pause. Okay. We're going to well, I mean, condition and vital signs of the mother, measure maternal blood loss, Any other events such as maternal incontinence, infant resuscitation, or perineal tears. Many healthcare facilities have a recovery room where the mother and newborn are taken after delivery and where the mother and father can fondle and care for their newborn during the first hours. In some facilities, the newborn is first taken to the nursery for an initial admission examination and then returned to the recovery room. I would know that usually in a lot of facilities we have what's called a nursery, and that is for the infant's initial admission examination and then return to the recovery room. Other Others admit the newborn when the mother arrives in the postpartum area. Immediately following delivery, the woman may experience extreme fatigue, close to exhaustion, just as she would after any extremely vigorous physical activity or hard work. At the same time, she is usually relieved and excited. She is usually interested in seeing and holding her newborn and having a visit with her partner. The bonding between parents and newborns should be encouraged a motherfucking sap, okay? The bonding should be between the parents and the newborn should be encouraged immediately. Allow time for the family to be together ASAP. If both mother and infant are stable, you should provide the family with privacy during this time. Observe the mother closely for several hours after delivery for signs of complication. In addition, document any maternal complaints. Observation of day together. You want to check the mother's blood pressure and pulse at least every 15 minutes for the first 1 to 2 hours or until it is stable, and then every hour, well, every half hour for an hour or longer. I will know this right here. After she has given birth, every 15 minutes for the first hour or two, or until it is stable, and then every half hour for 1 hour or longer. Usually, after the first 12 hours, you will check vital signs every 4 hours for 12 hours, and then every 8 hours if no difficulty arises. For the first, so I would know all of that. And usually, after the first 12 hours, we're going to check the vital signs every 4 hours for 12 hours, and for 8 hours, and then every hours if no difficulty arises. When taking vital signs, also check the fundus of the uterus and perineum. The reason for keeping a close check on the fundus is to ensure that it remains firm and contracted. If it becomes soft and boggy, hemorrhage could occur. Remember that because we just talked about the fundus over here somewhere about massaging the fundus right here. You may be instructed to administer oxytocics or massage the fundus gently to minimize blood loss. So right here it says the reason for keeping a close check on the fundus is to ensure that it remains firm and contracted. Because if that bitch becomes soggy and was soft and boggy, hemorrhage could occur. Teach your mother to assess her own uterine fundus. If nursing measures are not effective, the physician may order administration of an IV intramuscular oxytocin drug. Common oxytocin drugs are oxytocin or oxytocin and methyl- methylergonovin malate. So I would mainly remember that because this is the main one that they use. A rise in fundus may indicate, okay, and then you can find that in 6162 for for medicine. What is it? Oh, right here. So it tells you about oxytocin or oxytocin, which is pitocin, and it tells you about hell methogen. So right here, I don't know if I would. Mm, as far as the now, I'm not remembering none of that, but I remember this right here. Expected effect for oxytocin. Is used to initiate and meaning induce labor or augment labor contractions that are weak or ineffective. Also used after the delivery of the placenta to contract the uterus. Adverse side effects. This is going to be for the mother. Unpredictable individual response, hypertonic uterine contraction, tetanic uterine contraction, cervical and vaginal laceration, amniotic fluid embolism, water intoxication. And then for the fetus, for oxytocin, fetal distress or birth injury. Now, nursing consideration as a nurse, what we're going to keep in mind is contraindication to use. Any obstruction that will interfere with the descent of the fetus, hypertonic or uncoordinated uterine contraction, fetal distress, any contraindication for vaginal birth. Amount and rate of administration must be carefully controlled. This can be done effectively only by use of the IV route, using an infusion pump. Type of solution, amount of oxytocin added, and rate of infusion vary according to agency protocol or physician preference. Evaluate fetal heart rate every 15 minutes when given during labor, I'm sorry. To prevent water intoxication, give an electrolyte solution, avoid infusing high volume of fluid, and avoid using high doses of oxytocin for prolonged period. So I would definitely know it from here all the way down. I'm not trying to remember 1.2, whatever the hell that is, because I sure don't know, or I'm not trying to remember that. I'm remembering this, the expected effect, the adverse side effects for the mother, the fetus, and the nursing consideration. Now, right here for methogen, expected effects. Methogen is going to have a strong, persistent uterine contraction that lasts for hours. Okay, expected effect, it's going to be strong, persistent uterine contraction that lasts for hours. Adverse side effects, hypertension is primary side effect. May also cause headaches, some chest pain, palpitations, and oh shit, and dyspnea. Damn throat got itchy. And dyspnea, meaning difficulty breathing. Nursing consideration for this drug, methalengonovin, should never be given until the fetus and placenta have been delivered. We're not going to give this shit until the fetus and the placenta have been delivered. Shit, my throat itchy. And check the woman's blood pressure before giving the medication. If elevated, we're not going to give her this medicine. I will know this. This is one I would definitely remember or try to remember. So I'm coming back up here. Where the fuck was I at? Okay, I was right there. A rising fundus may indicate uterine hemorrhage. If the fundus does not become firm with massage, report this immediately. We need to know that. A rising fundus may indicate uterine hemorrhage. If the fundus does not become firm with massage, report that bitch immediately. A fundus located to the right of the midline often indicates a full bladder. So if the fundus is to the right, that's a full bladder. Water will usually return the fundus to its earlier location. If this does not occur, notify the team leader. I'm gonna know that too. I know that too. Check perineum to make sure the stitches are intact. Be sure no excessive bleeding, edema, or bruising is found. This is everything that we need to know. This may be a whole select all that apply. Lochia, I guess this lochia is the vaginal discharge that occurs following delivery. I would know that. Lochia is the vaginal discharge that occurs following delivery. It consists of blood and the tissues of the uterine lining as it breaks down. Immediately following delivery, lochia is bloody and should be moderate in amount. While wearing gloves, check lochia during the immediate postpartum period. I would definitely know that. Observe the amount, character, and color. I will know that. The amount is described. This is what you need to know. The amount is described as scant, light, moderate, or heavy. It should have a fleshy or metallic, never foul odor. It should have a fleshy or metallic and a never foul odor. Okay, that's what we need to know out of that one. And it says figure 66-6 for that. So this is what we're talking about. Determine the volume of lochia by peri-pad saturation. So this one is scant amount, blood only on tissue when wiped or less than 1 inch stain. Right here we got light amount, less than 4 inch stain a period. Right here we got moderate amount, less than 6 inch stain a period. This is a heavy amount saturated peri-pad within an hour. Okay, that's what it looked like. Observe and record the woman's first voiding after delivery. Failure to void may indicate swelling or injury to the urinary system. Report if the woman feels the urge. When we see these reports, after you observing this shit, Okay, so I'm observed. And so if I find this, what am I going to report? You're going to report if the woman feels the urge to void but is unable to do so, or if the fundus shift to one side. If she is unable to void within 6 to 8 hours after delivery, catheterization may be necessary. Okay, so once again, observe, and record the woman's first voiding after delivery. Failure to void may indicate swelling or injury to the urinary system. Report if the woman's urge to void feels the urge to void but is unable to do so, or if the fundus shifts to one side. If she is unable to void within 6 to 8 hours after delivery, catheterization may be necessary. Maternal and newborn feeding. The new mother may be thirsty and hungry after delivery. Encourage her to drink fluids to replace those lost during labor and delivery. She can have solid foods as tolerated. So we're going to encourage fluids as soon as the baby comes, and she can have solid food if she's able to tolerate it. If the mother plans to breastfeed, encourage her to put the newborn to her breast in the delivery or recovery room. The newborn usually is alert at this time, and the stimulation of the breast encourages the secretion of natural oxytocin to contract the uterus. Okay. Once again, if the mother plans to breastfeed, encourage her to put the newborn to her breast in the delivery or recovery room. The newborn usually is alert at this time, and the stimulation of the breast encourages the secretion of natural oxytocin to contract the uterus. Transfers from the recovery room. The mother remains in the recovery room or is closely observed in the birthing room long enough to ensure that her condition is satisfactory, usually about an hour or two. When her condition is stable, she is transferred to a postpartum room if she delivered elsewhere. Record complete information about the delivery and other procedures on the woman's health record before she is moved. Check the charting from the delivery room and the recovery room to make sure the record is complete. So don't move it until the record is complete. Transfer this documentation with the woman. And you can find that in box 66-3 and 66-4. So these are necessary documentation regarding the postpartum. And we already read over these. So this necessary documentation for delivery. And this was the one 66-4 necessary documentation regarding the um, postpartum woman. Assessment of the fundus, firmness, consistency, firm, boggy, and results of massage. Is center or deviated, location, height. We need to know the position. Okay, this is the assessment of the fundus. The firmness is the consistency, firm, or is it boggy, and results of massage. Is center or deviated, meaning the location, where's the fundus located, and the height, the position. Height of the fundus. One possible way of documenting fundal position is shown below. So the U stand for umbilical. So two U, two fingers width over umbilicus. One U is umbilicus. So one finger width over umbilicus. U fundus at level of umbilicus. UI, U1, one finger width below umbilicus. U2, two finger width below umbilicus. Lochia. So the lochia would be rubra, sarasosa, alba. That's the character of it. Um, and the lochia was this again. This was the lochia. And lochia, excessive, moderate, scant amount. And then the odor. Like we said, the odor was supposed to be a going back up. It's supposed to be um fleshy or metallic, never foul odor. And like I said, observe the amount, color, and character and color. The amount is described as scant, light, moderate, or heavy. So that is the necessary documentation regarding the postpartum woman. Okay, now let's talk about the postpartum care. Give me 1 second. Now, postpartum refers to the first 6 weeks following delivery, the time during which we're talking about postpartum care, my bad. Postpartum refers to the first 6 weeks following delivery, the time during which the woman's reproductive organs return to their normal non pregnant state. I will know that. What does postpartum refers to? The first 6 weeks following delivery, the time during which the woman's reproductive organs return to their normal non-pregnant state. The general care of the postpartum client is similar to that of other clients. Observe the woman's overall state, appetite, activity, pattern of sleep, and rest and interaction with her newborn. Note the client's vital signs. Postpartum women are usually discharged from the hospital within a day or two. Client teaching on all aspects of postpartum care and documentation of this teaching are vital. The new mother must know that what to expect as her body undergoes the rapid changes of postpartum period and when to call her practitioner for assistance. So let's talk about the important changes in maternal anatomy and physiology. The process by which the reproductive organs return to their non pregnant state is called involution. I would know that. The process by which the reproductive organs return to the non pregnant state is called involution. To provide competent and safe nursing care to the postpartum client, you must understand the physiologic changes that occurred following childbirth. Uterus, immediately after delivery, the uterus weighs approximately 2 pounds, 900, that's 900 grams, right? And is about the size of a grapefruit. I'm talking about the uterus. It can be felt at the level of or slightly below the umbilicus. After delivery, it begins to return to its normal position in smaller size. When the process is complete, the uterus will weigh about 2 ounces, which is 50 grams, and will be low at or near the center of the pelvic cavity. So this is what we need to know. We need to know that. During the postpartum period, the uterus should be positioned midline and feel firm to the touch. The height of the fundus indicates the process of involution. By palpating the abdomen, the fundus can be located. Measure its height in fingers width above or below the umbilicus. That's this chart right here. The, by palpating the abdomen, the fundus can be located. Measure its height, fingers width above or below the umbilicus. Normal involution is occurring when the fundus descends one finger width each day. Record the fundal height as indicated. So normal involution is occurring when the fundus descends one finger width each day. And go back to box 66-4 to look at that. Abnormal finding include, this is what we need to know, abnormal finding. This is important. So if you know what the normal finding is, you definitely will be able to differentiate the abnormal finding. So the abnormal finding is if that uterus is deviated to the side, suspect a distended bladder. Increased bladder size will prevent the uterus from contracting and will contribute to excessive bleeding. The uterus should contract after the client's void. A soft or boggy uterus indicates relaxation of the uterine muscle and is also a danger sign. Remember that soft or boggy, it said it was something, it had something to do with it may be hemorrhaging going on. Lochia, normally the flow of lochia continues for 3 to 4 weeks with the following gradual changes. Lochia rubra is seen for the first 2 days. It is mostly red and bloody. It should smell like blood, slightly metallic. A foul odor indicates an infection. That's Lochia rubra. Lochia cerosa, no, Lochia cerosa starts after the bleeding diminishes. The color of the lochia changes to pink or brown tint for approximately the next 7 days. Lochia cerosa has a slightly earthy odor smell. So remember that. Remember the difference with the lochia and lochia alba, which is yellow or white, start on about day 10. At this point, the lochia has decreased greatly in amount. Lochia alba has an earthy smell. So both of these have an earthy smell. Lochia cerosa and Lochia alba and Lochia rubra, she has a metallic smell. Okay. The amount of lochia after delivery should be about the same as the blood flow during normal menstruation. Abnormal findings include large clots, foul odor. This is what we need to know. Large clots, foul odor, lochia that does not change colors and characteristics as described. Record the amount, color, and any other characteristics that may be significant. Teach the client to report abnormal lochia. Cervix and vagina. The cervix is soft and edematous following delivery. It constricts and firms during the postpartum period. The vagina, too, regain muscle tone and laceration and episiotomies heal. The vagina and vulva lose their congested purplish color. Do y'all remember what that was called? That was called the Chadwick. The, the Chadwick. I remember the Chadwick. That's when it's purple and blue and stuff. So remember when I said Wakanda and thinking about Black Panther, how they had all those blue and purple colors in there or whatnot. That's how I remembered the purplish color of the vagina and the vulva and also the cervix. It's called the Chadwick. And I was thinking about I don't know how the hell I did that. I was thinking about Chad from I ain't this about a bitch. Chad from Black Panther. Hold on. That damn thing made me okay. Okay, so that's where that color come from. The vagina and the vulva lose their congested color, and that's due to all of the blood pouring. It's just a lot of blood in that area. That's what causes it to be purple and blue looking. So purplish color and return to their pre-pregnant pinkish hue. You will not be. So now you got a pink cooler cat again. So you will not be able to assess cervical and vaginal changes. Doing so requires a sterile pelvic examination, episiotomy, and perineum. The client should turn on her side to facilitate a better view of perineal area. If the client has had an episiotomy or laceration, examine the area carefully to determine the healing process. Make certain the perineum is intact. You may need a flashlight. The mother will need a mirror. The episiotomy and any laceration should appear clean with very slight edema. The suture should not be pulling against the tissues. No any hemorrhoids to initiate measures to alleviate them. Abnormal findings include inflammation, redness, and discharge from the episiotomy or laceration, hematomas, ecchymosis, and edema. If the client is unable to ambulate, administer perineal care, apply a fresh perineal pad, usually to the panties, and pull the panties straight up. If using tab pads, attach the front first, okay? So that is for the episiotomy and perineum. Once again, because I ran through that bitch, the client should turn on her side to facilitate a better view of the perineal area. If the client has had an episiotomy or laceration, examine the area carefully to determine the healing process. Make certain the perineum is intact. You may need a flashlight. The mother will need a mirror. The episiotomy and laceration should appear clean with very slight edema. The sutter should be, this is telling you what it should look like down there. It should appear clean, very slight edema. The sutter should not be pulling against the tissue. Note any hemorrhoids to initial measures to alleviate them. Note any hemorrhoids to initiate measures to alleviate them. Abnormal findings include inflammation, redness, and discharge from the episiotomy or laceration, and also hematomas, ecchymosis, and edema. These are abnormal findings, and I would definitely know that for episiotomy perineum. It told you what it usually looks like, which is it should be very clean, and it's going to be a little edema. Abnormal is inflammation, redness, and discharge from the episiotomy or laceration, and also hematomas, ecchymosis, and edema. If the client is unable to ambulate, administer perineal care. Apply a fresh perineal pad, usually to the panties, and pull the panties straight up. If using tab pads, attach the front first. Now, abdominal wall and weight loss. The woman's abdominal wall often remains soft and flabby for several weeks following childbirth because of the extensive stretching of the tissue and loss of muscle tone. By approximately 6 weeks after delivery, the woman should regain muscle tone. It's not all, but she should have some muscle tone coming back. The new mother can begin an exercise program gradually. You want to do it gradually. You're not going to come out, as soon as you're 6 weeks up. Now you bench pressing, bench pressing 300 damn pounds, and you ran this bitch running marathons. So everything is going to come on gradually as far as your exercise program. As the birth attendant recommends, the length of time it takes for a client to regain her figure depends on the amount of weight she gained during the pregnancy, the amount of weight she lost during the delivery, the amount of exercise she has after delivery, her diet and eating pattern, and whether or not she is breastfeeding. Body weight decreases by approximately 12 to 15 pounds at delivery and by about 5 pounds during the next day due to loss of excess blood fluid. Now that ain't for everybody because I gained weight when I after I had my baby. I became very very swole. I had a lot of fluid on me because I had preeclampsia. So breast changes in the breast following childbirth prepare for the newborn's nourishment during the last half of pregnancy and the first few days postpartum. The breast produce colostrum, a thin yellowish secretion that provides vitamin and immune substances that protect the newborn against infection. On about the second or third day postpartum, the breast begin to secrete milk. Each time a newborn is put to a breast, milk is secreted, meaning lactation. So go back up here. Remember this before I get deep up into this. Changes in the breast following a childbirth prepare for the newborn's nourishment. During the last half of the pregnancy and the first few days postpartum, the breast produce colostrum, which is a thin yellowish secretion that provides vitamins and immune substances that protect the newborn against infection. That's what colostrum does. It is a thin yellowish secretion that provides vitamins and immune substances that protect the newborn against infection. On about the second or third day postpartum, the breast begins to secrete the real milk. So each time a newborn is put to a breast, milk is secreted. Lactation is the production of milk, occurs because of the release of the two hormones, prolactin and oxytocin. I would know these. How does milk come about? Well, how does the lactation and the production of milk come about? Because lactation is the production of milk. It occurs because of the two hormones, prolactin and oxytocin. Um, and that's the natural oxytocin. Oxytocin. It's not the one that they give you. As the newborn sucks the nipple, a reflex reaction occurs whereby the posterior pituitary gland releases oxytocin, which stimulates cells to produce milk and to move it to the milk ducts. The oxytocin hormone also results in uterine contraction, and mothers often experience abdominal cramping while breastfeeding. Okay, so that's what happens. The oxytocin hormone it also results in uterine contraction and mothers often experience abdominal cramping while breastfeeding. The entire process is commonly known as the letdown reflex. The milk is said to let down or come in. Because the risk outweighs the benefits, medication to suppress lactation are rarely given to non breastfeeding mothers. For the first few days, the breast should be soft, the nipple should be intact without drying, cracking, or fissures. When the milk comes in, the breast will feel full and firm to touch. Abnormal breastfeedings are listed below. So these are abnormal breastfeeding. So you got engorgement, and what engorgement is, let me take a break real fast. Hold on. Oh, engorgement is the response of the breast to the presence of an increased volume of milk and sudden change in hormones. It usually occurs on the third to fifth postpartum day. The breast become tender, swollen, hot, and hard. The swelling may extend into the axilla. The breast may look shiny and red. The woman may experience a headache. She may have some breast discomfort and a slight temperature elevation at this time. So, this is what we need to know about engorgement, educating the client about it. So, with engorgement, it's the following measures help to relieve the nursing mother's engorgement. So, wearing a supportive bra will help. Frequent breastfeeding, apply warm packs to the breast for 15 minutes before nursing or standing in the shower with warm water spraying on the breast for 15 minutes before nursing. We're going to also, the following measures can help to relieve the non-nursing mother engorgement: wearing a supportive bra, avoid excessive fluid intake, placing cold packs on her breasts 3 to 4 times per day, avoid stimulation like hot shower spray, avoid manual expression or pumping her breasts, use medication, usually acetaminophen, as prescribed for discomfort. So that is what we're going to do to help the client get through engorgement. Okay. Now next, and we on page 1059 in the new book. You can find engorgement. It's the same shit. Now let's talk about this bladder real fast. Bladder. Pregnancy and labor place added strain on a woman's urinary system. The abdominal muscles may be weakened. In addition, bruising and swelling of the urethra and general loss of muscle tone are common. The involution process places an increased demand on the kidneys and bladder as the mother fluid balance is restored. Because of these factors, new mothers may have stress incontinence or difficulty voiding. Palpate the bladder for a rounded bulge in the suprapubic region, which indicates distension. By questioning the clients regarding voiding, you can gain information related to the urinary system. I would definitely know that. And I would know about the abnormal, excuse me. I would know about the abnormal urinary system findings that which includes voiding in small amounts, residual urine, dysuria or dysuria, um, bladder infection, urinary retention. And when we say residual urine, that means the urine is still in there. After she done voided, it's still urine in there. GI system. The mother may be constipated for 1 to 2 weeks following delivery because the abdominal muscles have been stretched and the intestines have been inactive. Whether or not the mother had hemorrhoids during pregnancy, she may have problems with them after the birth. Okay, so the mother may be constipated 1 to 2 weeks following delivery because of the abdominal muscles have been stretched and the intestines have been inactive, if that's a question on the test. Extremities to check for thrombophlebitis. The client's legs should be exposed. Ask the client to straighten her legs on the surface of the bed and to flex her feet towards her face. Abnormal findings in the legs include redness, pain, and swelling along the path of the vein, may indicate a superficial thrombophlebitis. Pain behind the knee or flexing of the feet indicate a positive homing sign and suggest thrombophlebitis. Okay, so we know about thrombophlebitis. So this, I think, this is something that is definitely important to know because that's a blood clot. Observation and data gathering to prepare the client the postpartum assessment. Ask her to empty her bladder and then lie flat in the bed. We talked about that, before she even have the baby, she needs to urinate. Even after postpartum assessment, having to empty her bladder and lie flat in the bed. Always follow standard precautions with body secretion. So that means wear gloves and protective, scrubs and shit like that, if you had to, and goggles and shit like that. And teach the woman to check herself frequently. So you can tell her about nursing care guidelines in 66-1, which is right here. We're going to read those in a second. So let me finish this. I always follow standard precaution. Okay, we said that. Ask her about any problems she may be having with her breast bleeding, such as lochia, sutures, cramping, constipation, or hemorrhoids. We need to know. Ask the client, ask the postpartum mother if she had any issues with her breast bleeding, lochia, which is bleeding, sutures, cramping, constipation, or hemorrhoids. Begin the postpartum observation with the fundus. I'm sorry. Oh, begin the postpartum observation with the fundus. Palpate the fundus if it is boggy. Perform fundal massage to encourage muscle contraction of the uterus and reduce blood loss. If the bulgy uterus does not become firm with massage, or if large clots are expressed with fundal massage, notify the team leader. Nursing alert: never massage a contracted fundus. Okay, you're never going to massage a contracted fundus. The rationale behind that is massage of an already contracted fundus may cause it to invert, which can present an emergency situation. Observe the amount, color, and odor of the lotion. Lotion. So this is important to know. You're never going to massage a contracted fundus. For the first few days after delivery, the mother may have painful cramping as the uterine muscle contracts. These cramps are called after pains and are more likely to occur in multigravidic or gravitas, however, gravitas. But it said it's a Latin word, so that's why I'm rolling it like that. Breastfeeding stimulates uterine contraction. Breastfeeding stimulates uterine contraction, and we already talked about that. I haven't forgot about this. I'm gonna read that in a second. And therefore, okay, let me go back up and read that sentence. Breastfeeding stimulates uterine contraction and therefore often brings on the cramping, and analgesics may be ordered as needed for these pain. Heat applications is sometimes helpful. So let me read this real fast before we go on talking about observing. So this is nursing care guidelines 66-1, and we're pretty much talking about postpartum period, the postpartum period. So we're gonna check blood. This is some shit we need to know. Um, Immediate postpartum care. You want to check blood pressure, check the blood pressure, and post every 15 minutes, times 1 to 2 hours, or unstable, then every 30 minutes, every hour, then every 4 hours, times 12 hours, or its order. This is immediate postpartum care. So check uterine fundus, lochia, and epiostomy, episiotomy at the same time as blood pressure and pulse. That's when you're going to check the uterus, lochia, and epiostomy at the same time as blood pressure and pulse. Check for any signs of hemorrhage. That means you're going to check the perineal pad and be alert to the possible pooling of blood under the client. Monitor for urinary distension and document first voiding for quantity of urine. Ask the mother if she had any difficulty voiding because urinary retention is not uncommon. Swelling of the urethra and around the perineal area can inhibit the patency of the urinary meatus. If voiding has not occurred in 6 to 8 hours, or if she voids in small frequent amounts, like less than 100 milliliters, notify the healthcare provider because she may need to get a catheter. Monitor interactions with infants. If signs of bonding are not present, determine cause. Are you in pain, or there's some complication, or you just exhausted? We need to determine the cause if there's no type of interaction with the mother and baby, and address these issues. Psychological and emotional issues that interfere with normal bonding need to be addressed ASAP. So if it's none of this and it's just a psychological or emotional issue that's interfering with the bonding, with the normal bonding, we got to address those ASAP. General postpartum care. After the first 12 hours, check vital signs every 4 hours times 12 hours, and then every 8 hours. If there's no type of abnormality. Check breast fundus, lochia stitches if present, and legs for signs of thrombosis at least once every shift. Memory aid, it says bombo, oh, bubble, like it's dragging the word bubble. So there's breast, uterus, bladder, bowel, legs, lochia, epiostomy, emotions, education. That is what you're checking. That is what you're checking. So memory aid to remember those things is what bubble, breast, uterus, bladder, bowel, legs, lochia, epiostomy, and emotion and education. In the breastfeeding mother, observe that the breast begin to produce milk by the third or fourth day. Monitor that the breasts are not engorged. Okay. In the breastfeeding mother, observe that the breasts begin to produce milk by the third or fourth day. Monitor that the breasts are not engorged. In the non nursing mother, observe that the breast engorgement does not last more than 2 to 3 days. Check that the fundus remains firm and contracted and moves downward. If the fundus is soft and spongy, cup a hand around the fundus and massage it gently until it becomes firm and contracted. Monitor elimination patterns like urinary and bowel until they return to the normal pre pregnant state. Check that mother demonstrates correct perineal care. Once again, monitor elimination patterns like the urinary and bowel until they return to the normal state, pre pregnant state. Check that the mother demonstrates correct perineal care. Evaluate for thrombophlebitis in the legs. Check for presence of a positive Holman sign. Observe that lochia progresses on schedule from lochia rubra and lochia alba. You can go back and look at what those things, and it was one more lucia or something. I think it started with an S. Monitor incision. So that's episiotomy or cesarean incision, if present, for healing. So you're going to monitor the incision. You know, if she had an episiotomy or a cesarean incision, if present, for healing. Evaluate quality of maternal newborn bonding and family dynamic. And then lastly, we're going to educate the mother, family, and significant others so they know what to expect after discharge. Now, going back right here, observe the episiotomy or laceration for healing, provide perineal care, change the sanitary pad. While taking it in the back, ask the client, well, ask the woman to roll onto her left side, like the right buttock, well, lift the right buttock and examine the anus for hemorrhoids, ice packs, witch hazel pads, like they're called tucks, suppository creams, ointments, or sitz baths may be necessary for hemorrhoids. Wash your hands and then examine the titties. Observe the titties for tightness and redness and palpate for fullness and temperature. Okay, that's what we're going to do with the client titties. We're going to observe the titties for any type of tightness and redness, and we're going to palpate for fullness and temperature. Observe the nipples for drying, cracking, or fissures. Teach the mother, teach the mother to examine the nipples to determine what they are. Well, to determine they are in good condition and observe them for uh, cracking, caking, dryness, or bleeding. That's what we're observing for: cracking, caking, dryness, or bleeding. If the mother is breastfeeding, observe whether her nipples protrude sufficiently for adequate nursing. She can palpate protrude sufficiently for adequate nursing. Oh, my bad. She can palpate the breast generally to determine if they are soft, firm, or engorged. Okay. Engorgement in the nursing mother generally subsides within 48 hours if the mother feeds her infant from both breasts every 2 to 3 hours. Okay, that's important to know. Engorgement in the nursing mother generally subsides within 48 hours if the mother feeds her infant from both titties every 2 to 3 hours. Alternating the breast that she uses first on each feeding. Engorgement in the non nursing mother is treated with breast binders and ice packs. So for the mother that don't want to, provide titty milk, is often treated with breast binders and ice pack. Ice pack. I know it, and I think it was that I didn't do it because ended up um I ended up breastfeeding, but my friends that did not want to breastfeed, they used cabbage. They used cabbage over the breast to dry it up. Constipation is a common problem for new mothers. Diet, adequate fluid, and activity helps to regulate this. Okay, it's going to help regulate this condition. Many birth attendants routinely order stool softeners such as docosate sodium, that's Colis, or a mild laxative until good bowel functioning is reestablished. The woman may need a suppository or small enema if a laxative is ineffective. This is something important to know as far as the nursing alert. The new mother should never take an enema without a specific physician order. An enema could cause the rupture of episiotomy sutures and could be the source of incisional infection. So Don't go out here out there just saying, "Oh, I need an enema," and you in the hospital and you send your baby daddy to go and get you a damn enema after they told your ass you can't have it, because guess what that enema may cause? It may cause the rupture of the epiostomy sutures and could be the source of incisional infection. Now, client teaching, what we want to teach the client. Client teaching begins early at the time of admission because mothers are often discharged a short time after delivery. So the mother receives instruction in these aspects of self-care: breast care and nursing, perinatal care and care of the stitches, fundus observation, fluid intake, voiding, ambulation, and engorgement, involution. So that is what we're going to teach them about: breast care and nursing, perinatal care and care for the of the stitches, fundus observation, fluid intake, voiding, ambulation, engorgement, and involution. So this is the doctors say sodium chloride expected effect is it is a stool softener. Adverse side effects, really none. It's none. Nursing consideration, colitis is not a laxative, but simply makes the stool soft to pass. Because we learned that in chapter 65, like you're not really going to give us, like you're not giving a laxative, you're giving a stool softener. So also, we want to teach the client how to massage her uterine fundus and document this teaching. The client should use a mirror to check her stitches. Teaching the client the normal sequence of low shear changes is important, as she will probably go home the first or second postpartum day. She must know danger signs to uh, she must know danger signs so she can spot a problem early and report it to her birth attendant. Did I just? Oh no, I didn't read this. Breastfeeding. Reinforce the benefit of breastfeeding for the client and newborn nursing and the newborn. Nursing a newborn is beneficial for many reasons. This is why it's beneficial to nurse your newborn, and I think we should know this. Breast milk is readily available and convenient. Breast milk is always the correct temperature. Breast milk contains antibodies. Nursing helps in the bonding process. Nursing speeds evolution. Breast milk is less likely to cause allergic reaction and other difficulties, and breast milk is cheaper than formula. Once again, breast milk is readily available and convenient. It's always the correct temperature, and it contains antibodies. Breast milk also, with the nursing, it helps in the bonding process. Nursing speeds evolution. Breast milk is less likely to cause allergic reaction and other difficulties, and it is cheaper than formula. Most mothers can nurse their babies unless complications such as severely retracted nipples, infections, or breast malformation arise. Okay, this is when a mother is, is having some complications and she's really not going to be able to breast, breastfeed the baby, and that is due to severely retracted nipples, infection, or breast malformation may arise. So the first requirement for breastfeeding is a good supply of milk. The woman's emotional status, diet, fluid intake, and amount of breast all influence milk production. What influenced the milk production is going to be based on the woman's emotional status, her diet, fluid intake, and amount of breast all influence the milk production. I would know that. Generally, the mother who is happy wants to nurse her newborn and is not worried or overly tired has an excellent chance to have a good milk supply. All right. And an adequate diet based on the My Plate framework and ample fluids are essential. Intake of dairy products and fluids may be increased. Supplemental vitamins are often prescribed for breastfeeding. Educating the client 66-3. Changing the perineal pad. When removing a soil pad, the client should pull her panties straight down. If using a sanitary belt, she should unhook the pad from the front first. Advise the client always to start removal of the perineal pad by first removing the pad from clean areas in the front and then remove the pad from the dirty areas near the rectum. When applying a clean pad, she should hook it onto the front first, which helps to prevent infections. Now, let's read over here. Expression of milk when artificial emptying of the breast. Hold on. What the hell are you talking about? Expression of milk expression of milk means artificial emptying of the breast. It may be used when a preterm newborn must be fed in the newborn intensive care unit or for the convenience of a working mother. That's when you're gonna. That was my baby was in the NICU. That's newborn intensive care unit, NICU. That's the NICU, and you're going to just pump. You're gonna pump so they can have milk to give those babies. If you are because breast milk is the best milk as far as the baby developing. Brain is good for the brain. Like I said, it has antibodies, so it's good for the immune. It is also good for the growth of the baby, especially if it's a premature baby. It's going to put that weight on them. So just keep in mind the electronic breast pump offers the best method for expressing milk because the suction is steady and controlled. I don't know if they still have these at the hospital, but when I was in the hospital, they provided me one, and then my boyfriend's mother provided me one. She bought me one. Milk can also be expressed by hand. Milk that is to be used later should be collected in a sterile bottle and refrigerated. Refrigerated milk should be used within 48 hours. Breast milk can be kept in a home freezer for 1 month or in a frozen food locker for 6 months. Okay. Once again, we need to know about this. This is important to know. Um, milk can milk also can be expressed by hand. So you can just squeeze it, milk your titties like you a baby cow, some shit. Milk that is to be used later should be collected in a sterile bottle and refrigerated. Refrigerated milk should be used within 48 hours. If you're going to put it in the refrigerator, it needs to be used within 48 hours. But if you're going to put it in the freezer, that bitch can last about a month, or in a frozen food locker for about 6 months. That means that's that real cold ass locker. And ain't nobody putting no damn titty milk up in no goddamn locker. Put that bitch in your freezer, and that bitch can last for about a month. Bottle feeding. Bottle feeding. Although breast milk is the preferred milk for most infants, there are times when it is not the best milk for a particular baby. For instance, some bloodborne infections such as HIV. This is important to know. Such as HIV, maybe is transmitted through breast milk, so we are not going to let the mother breastfeed. The client who has chosen to bottle feed should receive equal support from nursing staff. The mother who does not choose to nurse her newborn should wear a bra that gives firm support. She may have fluid as desired for the first 24 hours after delivery, but after this time, fluids are often restricted. Ice packs and breast binders can be applied to reduce discomfort. Perineal care. Perineal care. I would know this too. What are we going to, for when the lady is, when the mother has discomfort going on and she don't want to breastfeed, we're going to provide her with ice pack and a breast binder. Now, perineal care. Perineal care provides comfort and cleanliness and prevents odor and infection. Encourage the clients to use a peri bottle. A flexible plastic bottle contains clear, warm water. A sitz bath. Look up a sitz bath. That's what they use for hemorrhoids. It's like a little bitty. It looks like a urinal, and on that urinal, it's like a sprinkle. You know how in rich folks' houses they have that little sprinkler that clean your booty out. Well, that's basically what a sitz bath is, or Surgigator, which is a handheld sprayer device after toileting, whether or not she has an episiotomy. In addition to promoting, that means it doesn't matter if she has an episiotomy or not. That cooler cat need to be clean down there. It don't need to be funky. It don't need to have any type of infections going on. In addition to promoting healing, these methods help keep the perineum clean and decrease the risk of infection. You may give initial perineal care with the client in bed or on a bedpan. Clean the client when the client is ambulatory. She may attend to it herself. Methods vary, but this the purpose is the same: to avoid contamination from fecal material. Perineal care is necessary after the client voice or has a bowel movement. Okay. It's very necessary after the client piss or has a bowel movement. Teach the client to wash her hands and to change the perineal pad every 2 to 3 hours during the day. Help remove the pad she is wearing carefully, moving from front to back, and place it in a paper bag for later disposal. After voiding or a bowel movement, teach the woman to spray tepid water onto the perineum from the period bottle, sitz bath, or surgigator. Use fresh toilet tissues to pat dry from front to back on each side and then in the middle. Discard the tissue in the toilet. Do not use undue pressure, which can cause discomfort. Okay, do not use undue pressure, which can cause discomfort. Without touching the inner surface of the perineal pad, the woman should fasten the tab of the sanitary belt or attach the adhesive side of the pad to her panties from front to back so that it will not slip forward. I think that is something I will remember because they didn't mention like front to back a couple of times. So how she would put that pad in is front, then slide that bitch to the back so it won't slip forward. So a soothing analgesic ointment or spray may be applied as ordered. Witch hazel tux pads may be used. Frequent sitz baths 4 times a day will increase the mother's comfort and promote healing of the episiotomy. Oral analgesics and warm or cold compresses may be ordered to relieve discomfort. Squeezing the buttocks together before sitting down helps provide a cushion. Okay, so squeeze that ass together before sitting down helps provide cushion. Bathing. When the mother is ambulating and stable, she is permitted to take a shower. You will need to assist her the first time. Okay, I remember when I was in the after I had my baby, the next day I had to get up and the nurse came in there and she did help me take a shower because I had to get up. You have to get up as after C-section, so you want that's the next day. You don't have to get up the same day, but you definitely got to get up the next day so there won't any there won't be a blood clot or anything trying to form. Instruct the nursing mother to avoid using soap on the nipples. We talked about that in the last chapter because the nipples, that soap will cause it to dry and crack. The nipples have their own oil, they create their own oil. So don't fucking do it. Just use water on it. The client usually receives a bed bath on the first day after a cesarean delivery. So there's going to be a bed bath. They did not get my funky egg. Well, you know what? Because I didn't, my bad. I had a C-section. Well, you know what? Goddamn it! After cesarean delivery, no, they didn't give me no bed bath. I'm gonna go there and fly on their ass because they did not give me no bed bath out that day. Activity, rest, and diet. The new mother needs a combination of rest and activity. In most cases, she is up within 4 hours after a normal delivery, which helps to prevent respiratory and circulatory complications. Encourage the client to nap during the day, okay? Encourage that client to nap during the day. We're talking about activity, rest, and diet. In some cases, visitors may need to be restricted. Analgesics may facilitate her ability to rest. Now, I know one reason that we restrict visitors because they got on my ass is my blood pressure was high, and they didn't want me to be on the phone. They didn't want the TV on. They wanted me to sit in a dark room with the lights off to calm my nerves down. So visitors may need to be restricted if something like that is going on. Assist the new mother in her initial ambulation. Encourage her first encourage her first to sit on the edge of the bed and take deep breaths. If she feels dizzy, she should not get up further until that sensation passes. When she gets up, she should move slowly. Remain with her the first few times until she feels totally stable. Sometimes the client experiences an increase in low while ambulating, which may cause her alarm. Monitor the flow and assure the client that the increase is likely due to gravity when arising. Explain that the increased low shear helps the uterus to drain and to return to its normal position and size. The new mother should have a nutrient balanced diet. If she is nursing, extra quantities of milk and other liquids may be added. Remember that. If she is nursing, extra quantities of milk and other liquids may be added. And remember that gravity is the cause of, if she start feeling um, the lochia while ambulating, if she feels, the flow. Discharge, examination by, oh, thank you, Lord. Discharge, examination by the birth attendant. The birth attendant checks the client before discharging her from the healthcare facility. She is told to return for a follow up examination at the end of 6 weeks. And she is usually advised not to have sexual intercourse or use vaginal dish until then. Okay. It's been plenty of times. I know one of my friends, her mother, God rest her dead, her mother, she ended up knocking boots before her 6 weeks, and her brother, when they turn, both of them, like one of them turned is 1 years old, and the other one is one at the same time because they were born not even a year apart. Okay, they just a months apart, not even a year. Mama didn't wait on her 6 weeks. So discharge procedures and teaching. Routine discharge procedures are followed when the mother, and they're not twins. They're not twins, and they are 1 year. Like if one turned 32, the other one turned 32 as well. Like some, it's a good little amount of months later, but still, that means she had them in the same within the same year. So one was born in early. If one was born in January, the other one was born in September or October. So, because that's 9 months later. So, discharge procedures and teaching. Routine discharge procedures are followed when the mother and her newborn leave the facility, and specific OB procedures also are performed. The mother should be informed that menstruation will assume in 6 to 8 weeks if she does not nurse her newborn. If she does nurse menstruation, it usually delayed for 4 to 5 months or until she stops nursing. Okay, that is something to know. Teach that client. The mother should be informed that administration will resume in 6 to 8 weeks if she does not nurse her newborn. If she does nurse, administration is usually delayed for 4 to 5 months or until she stops nursing. I never knew that. Although ovulation does not usually occur during the nursing period, prolonging nursing is no guarantee that pregnancy will not occur. Okay, it's not guaranteed, baby. To a great extent, the degree of protection from pregnancy depends on whether the infant has all its sucking needs met at the breast. A baby who uses a pacifier or sucks on its fist will not provide as much stimulation to the nipple and therefore provides less contraceptive benefits. Many nursing mothers do become pregnant. Nursing mothers do become pregnant. The new mother should be aware that pregnancy is a possibility before the first normal menstrual period because, as a rule, ovulation occurs before menstruation. Okay. So, new mothers should be aware that pregnancy is a possibility before the first normal menstrual period because, as a rule, ovulation occurs before menstruation. Discharge teaching should also include normal maternal responses to sex and sexuality, contraception, and when to resume intercourse. At the time of discharge, rubella vaccine and ROD, immune globulin, ROGAM, gamelin RH, which we learned in the last chapter 65, you can administer it now to the RH negative mother. It's indicated because you remember you couldn't give that rubella because of it's live, so that's why you can't give it to them, and it can harm the fetus. So you could have did it in pre-conceptional before a woman was pregnant, or you're going to do it directly after the baby has been born. The newborn may be given the first hepatitis vaccine. All these medications require informed consent, so remember that. I would remember that before, giving a baby any type of medications. All medication requires informed consent. If the mother receives rubella vaccine, she must be cautious to avoid pregnancy for 3 months to avoid harm to the next fetus. Okay. If the mother receives rubella vaccine, she must be cautioned to avoid pregnancy for 3 months to avoid harm to the next fetus. The practitioner examines the mother and newborn approximately 6 weeks after delivery. The purpose of this examination includes making sure the mother's uterus has returned to normal size. Her episiotomy has healed and has no infection. No infection is present. Okay. That is the purpose of the examination. It includes making sure the mother's uterus has returned to normal size after the 6 weeks. Her episiotomy has healed after those 6 weeks, and no infection is present after the 6 weeks. The examiner will advise the mother at that time regarding resumption of regular activity. They'll let them know, okay, you can go on back to doing what the fuck you've been doing, you know, or hey, I found this, I discovered this, so we're going to hold off on going back to doing what the fuck you was doing until this is resolved. And that is you can answer these well, this is student census key points. This is something important to know. Let me see. You can go to page in the new book. This is on page um 1064. I would definitely look at this. This is application of external monitor. It's showing you how to apply the external monitor supplies and equipment that is needed. The fetal monitor and paper, the Doppler, which is the ultrasound, US transducer. You got the electronic fetal monitor, which is the taco dynam dynamometer. I know I'm fucking that word up all the way. Gonna need two straps and conductive jelly. Follow LPN, welcome steps, and then. So evaluate the head of the bed 15 to 30 degrees or place client in lateral position, and lateral is the side position. And the rationale behind that is elevation and uterine displacement decrease aorta and vena cava compression. We talked about that in this chapter and in 65. So, they shouldn't never be in a supine position because that puts pressure on the aorta and the vena cava. The OBRN will perform Leopold's maneuvers, which is a series of four steps used to palpate the abdomen to determine fetal position and lie. When the fetal placement within the uterus is estimated, two straps under the fetal. So that's rationale behind this is dislocates fetal position and best placement of the Doppler so the heart rate can be clearly heard. Apply conductive jelly to Doppler and place on the client's abdomen until strong fetal heart rate, FHR, is heard and consistent signal is obtained. Rationale is the jelly helps locate the area of the maximum fetal heart rate signal. Attach strap to Doppler and secure. The rationale strap should be snug, but not too tight. But not tight, okay? Not tight. Next, push recorder button if not already on. Rationale machine will not record data if machine is off. Next, place a dynamometer on the abdomen between umbilicus and top of fundus. And the rationale behind that is the fundus is the contractile portion of the uterus. Take care to avoid placing too high on fundus. Respiration will record on monitor if you place it too high. Attach straps to taco dynamometer and secure. And the reason you do that, the rationale is straps should be snug but not tight. If too tight, pressure sensitive button will not record data. Um, Adjust sound and equipment as needed, particularly when a procedure is performed on client's position or client's position is changed. And the rationale is the monitor is sensitive to change or disturbances to equipment. So adjust sound and equipment is needed, particularly when a procedure is performed or client position is changed. Okay. And then lastly, you want to review fetal heart rates and US data with ultrasound data with client and family. Use thorough description of the data. Rationale, this review promotes understanding of what the client and family will be observing on the monitor. And I would definitely know these things. And then this is the last thing we're going to talk about, and that's going to be the end of this chapter. So this is nursing procedure 66-2. We're talking about fundal massage. So the supplies you're going to need and the equipment are gloves, perineal wipes, or washcloth and perineal pads. The step is I think all of us had this done after you had a baby. I had it done before. Steps. Cup your hand around the uterine fundus at the level of the umbilicus. And the rationale, meaning why we do it, this is the best position to start to palpate the fundus. So you want to cup your hand around the uterus fundus about the level of the umbilicus. And the rationale is the best position uh, to start to palpate the fundus. That's the best position. So the upper hand is around the uterus fundus, the upper hand, at about the level of the umbilicus. The other hand stabilizes the uterus at the level of the um, syphilis, uh, syphilis pubis. All right. And then right here it says place your other hand over the oh shit symphysis pubis to stabilize the uterus. The rationale behind that is two hand technique stabilizes the fundus in the abdomen. You do that two hands technique is going to stabilize the fundus in the abdomen. So the fundal massage is viewed from the side. This is how it's viewed from the side. Okay. Next, we're going to rotate your fundal hand gently. Rotate your fundal hand gently. The rationale is your touch must be firm but still gentle so that the fundus can be massaged but has a minimal amount of pain for the mother. Okay, rotate your fundal hand gently. Rationale is your touch must be firm but still gentle so that the fundus can be massaged but has a minimal amount of pain for the mother. And that's rotating your fundal hand gently. Number four, continue this massage until you feel the uterus becomes a firm globe. Continue this massage until you feel the uterus becomes a firm globe. And the rationale is the uterine muscle responds to stimulation by contracting. The uterine muscle responds to stimulation by contracting. When contracted, the figure eight muscle of the uterus clamp off the blood vessels, reducing bleeding. When contracted, the figure eight muscle of the uterus clamp off the blood vessel, reducing bleeding. Number five, observe the passage of large, numerous, or frequent clots. Notify healthcare provider for the changes of or worsening status. I would definitely report that. Rationale is numerous, frequent, and or large clots indicate a soft and spongy, non-contracted, bulgy uterus and or active hemorrhaging. When you see that word bulgy and soft and spongy, we know something going on. The person is bleeding on the inside and it's causing it to be soft, spongy, and boggy, meaning non-contracted. Number six, when the woman's vulva and perineum, oh, I'm talking about when, clean the woman's vulva and perineum. And the rationale behind that is blood is an excellent growth medium for bacteria. Good hygiene in the area helps to prevent urinary tract and postpartum infection. So that's why you want to keep that clean. You want to avoid preventing urinary tract and postpartum infection. Number seven, apply a clean perineal pad. The reason we do that, the rationale is a clean pad provides an accurate baseline observation during the periodic inspection of postpartum bleeding. On a clean pad, decrease the chance of bacterial growth. Also, the woman feels clean and refreshed. Y'all know why the fuck we would change a pad and keep a pad clean? We all women. We have, periods. So that's why we do it. And that is it for chapters. Oh shit, for chapter 66. Um, if I see any question, if I see anything, I'm gonna listen to it again, and I'll be putting important information in the in the comment section. Do not inbox me. I'd rather you put it on the video so everybody can see. So if you see anything important, or if you say, you know what, remember this by this, comment, leave a comment so we can all write it, notate it on our own personal notes. That way we can all y'all know what the fuck I'm trying to say. We can all share each other, share information. So all right, that's it.